Good afternoon, and welcome to Bill Hearings for House Health and Government Operations Committee. Delegate Hill, good afternoon. I'm your chairman, Jocelyn Peña-Melnick, joined by my vice chair to the left, Bonnie Collison. I'm going to go through some of the rules in this committee just to make things easier. Then we're going to start with the bill hearings. I apologize. We usually start on time, but it is 40 more days until the end of session, and our schedules do not belong to us. So the word here every day, remember it. What do you think it is? Flexibility. We are Gumby. What else? Anyone else want to come up with another word? Okay. So I kindly ask for your patience if we encounter any technical or streaming issues. Sometimes it does happen. Please set your electronic devices to vibrate, which I did. So live by example. Please do that. As a reminder, there's no food or drink allowed in the gallery because our staff does not have the time to clean after us, okay? You will see that we do drink, although I need a refill, because we're here for many long hours. So for the sponsor in this committee, I have decided not to time the sponsor, but please don't abuse it. Everyone else has 2 minutes. And you have to pay attention to the timer that is displayed on the screen. And when it goes off, I'm not going to interrupt you. Trust me, I don't want to do that, but please wrap it up. Don't make me do that. We actually alternate between favorable, unfavorable, or favorable with amendment, and unfavorable. And when there's a lot of favorable and very few unfavorable, I try to take a break just to be balanced, okay? For the committee, you have been doing amazing work. Just before this, we voted. We spent over an hour voting on bills that went to subcommittee, right? They were able to get vetted. And I appreciate you for all the work you have been doing and the work that you're going to do. These are long hours that we spend here. We love the work, and are very grateful of the public's involvement. Members of the public are able to view the live stream of this hearing on the Maryland General Assembly website and on the YouTube channel. Today, this is the bill order. However, I reserve the right to change it because you'll see that some of our members are not in. It's because they have bill hearings in other committees, and they come and go. But we do listen, we watch the recording, and we read everything that comes in, okay, as well. And if a delegate is not here, I have to move it or a witness. But for now, at 2:31, this is the order. House Bill 930, Delegate Lopez. 970, Delegate Woods. 1031, Delegate Miller. 1059, Delegate Fair. 378, Prince George's County Delegation. 108, Delegate Metzgar. 373, Delegate Grammer. 1357, Delegate Riley. 1082, Delegate Peña-Melnick. 1045, Delegate Peña-Melnick. 1246, Delegate Johnson. 1243, Delegate Johnson. 813, Delegate Johnson. Delegate Johnson, are you going to owe us a dinner? Because we're going to be here late. See, we have this rule that if you keep us here late, you have to buy dinner for the committee. A one-sentence presentation. Oh, that would be the day. All right. House Bill 930, Delegate Lopez, Public Health Abortion Grant Program Establishment. Good afternoon.
Good afternoon, Madam Chair and Madam Vice Chair and fellow members of HGO. For the record, I am Delegate Leslie Lopez here for HB 930. I sit before you today while our state and our country are in a crisis of uncertainty. Our finances and our foundational rights are in question. But I'm also here today with an opportunity to meet the moment. Put it closer, excuse me, for Delegate White Holland, who's not here. And we can create stability in an area that is widely supported by all of our districts. I'm here to ask for your support for HB 930, which creates a stable funding source for abortion care without a penny from taxpayers. So here's what the bill does technically. HB 930 establishes a public health grant program under the Maryland Department of Health to reimburse providers for abortion costs. This fund comes from surplus insurance premiums mandated by the Affordable Care Act. It holds approximately $25 million and generates an additional $3 million annually. There we go. Is that better? Okay. No state general funds are required. Why is this bill important? Well, an unpredictable patchwork of rights and restrictions forces our urgent attention. Maryland has been and is a proud leader on reproductive health care. Other states look to us to innovate, implement, and protect this fundamental right so that they can follow suit. Our work is more important now than ever before because the Dobbs decision put the right to abortion up to individual states. But the state-by-state approach brings new challenges every day. Nearly half the states have attempted to ban abortion, and 13 states have a total abortion ban. Since the Dobbs decision, 76% of the independent clinics in our country have closed. That's a staggering number. Another reason why we need this? Unpredictable sources of funding. We all know the budget posture that we're in this year. Funding issues, unfortunately, are not limited to state budgets. Nonprofit abortion funds in Maryland and nationwide are struggling to meet the growing demand, especially from out-of-state patients. You'll soon hear from Planned Parenthood of Maryland and the Baltimore Abortion Fund, who will give firsthand accounts of financial challenges. Private donations surged after Dobbs, but they've since leveled off. Federal restrictions block public health grants for abortion care, and philanthropic support, though appreciated, is an unstable model for this vital medical care. And so how do we pay from this? You'll hear a more detailed account by my fellow panelists, but here's the broad strokes. For nearly 15 years, the Affordable Care Act has required exchange plans to charge $1 per member per month exclusively for abortion coverage. These funds must be kept in separate, segregated accounts, and those accounts can accrue interest. Though originally intended to be cumbersome, insurers have adapted to these rules, as you will see in their letter of information. The Maryland Insurance Administration believes there are $25 million in funds currently available and an additional $3 million generated annually. Our bill proposes a grant program that will be administered by the Department of Health, who you'll hear from shortly. Awards may be used for the reimbursement of the cost of the abortion procedure, regardless of insurance coverage. The program and participants are prohibited from imposing restrictions inconsistent with law. The bill also includes special privacy protections for personal information about people administering the grants, providers, and patients. And to ensure the funds are being used for direct services, MDH must award 90% of total program funds to grantees and may use 10% for administrative costs. So who supports this bill? Well, on the panel today, you'll hear from doctors, elected officials, legal organizations, and advocates from both urban and rural parts of our state. Additional favorable witnesses today will be from the Comptroller's Office, the Department of Health, and the Office of the Attorney General. Also, please check out the written testimony from 37 state and local and national groups. This bill also has 82 co-sponsors in the House, with additional support that was expressed after the bill was filed, and that's because we dropped it on the anniversary of the Roe v. Wade decision. What you won't hear today is opposition from the insurance carriers. I'll close with this. Abortion has long been used as a political football, but the truth is clear. It is widely supported across political parties. 76% of Marylanders supported adding full reproductive access to our Constitution. And every single legislative district, represented by every delegate in this room, supported the constitutional amendment with a strong majority. We'll have lots of hard choices to make this session, but this bill is not one of them. Today, we have the opportunity to invest in the health of residents, improve economic security for our state, and to meet the moment with no burden to taxpayers. Abortion is not a luxury, it is health care, and Maryland voters resoundingly agree. And so with that, I urge your favorable support.
All right, thank you. Who would you like to go next?
Which one with Robin?
Good afternoon. Robin Elliott here today on behalf of the Women's Law Center of Maryland in full support of this legislation. I'm just going to add a little bit about the origin of this idea. The reproductive health community has known for a long time that this moment was coming. We knew for a long time that there were cases in the court pipeline that would overturn Roe v. Wade. The Maryland General Assembly has been incredible partners in supporting Maryland rising to the occasion. In 2022, you passed legislation making sure all insurance plans that Maryland regulates, including Medicaid, covers abortion care. The piece left are people who do not fall under that particular law. As you all know so well, because you hear so many insurance bills, only about 1/3 of Marylanders who have insurance coverage are covered under state laws. The rest are subject to ERISA. There are also many people who are uninsured or who cannot use their insurance because there is still a stigma associated with abortion care, and they are afraid of documents going home and alerting family members. So what this bill does is it creates a public health grant program to fund abortion care for people who are uninsured, underinsured, or cannot use their insurance, just like any other health care. We have coverage or grant programs for breast and cervical cancer screening, prenatal care, or full range of things. We do not have any grant programs for abortion until potentially now. Thank you very much. I ask for a favorable report.
Thank you, Madam Chair. For the record, my name is Councilwoman Felicia Porter, representing Baltimore City's 10th District and Chair of the Public Health and Environment Committee. As a public health scientist for over 15 years, I'm here to express my strong support of HB 930, which affirms that abortion care is health care and, most importantly, does not discriminate based on state residency, insurance coverage, immigration status, and more. With the public's decision to enshrine the right to abortion in the state constitution, this bill will establish a groundbreaking, first-of-its-kind program to ensure meaningful access to that right. Access to abortion care in Maryland is increasingly at risk due to the unstable national landscape, an overwhelming strain on our healthcare system, and disproportionately impacting Black and brown women, young women, and uninsured individuals. These communities already face systemic barriers to maternal health care, and the closure of abortion funds multiple days a week due to insufficient funding only exacerbates these challenges. Despite the urgent need, there are also currently no state-level public health grant programs dedicated to sustaining abortion care, a direct consequence of the Hyde Amendment, which has prohibited federal funding for these services. HB 930 seeks to address these disparities by creating sustainable, dedicated source of funding for abortion care without using taxpayer dollars. With fewer than 5 abortion providers in Baltimore City, access to care remains a significant challenge. Recognizing the need to protect reproductive rights, 86.4% of Baltimore City voters supported question 1, demonstrating the overwhelming public support for abortion access. By prioritizing funding specifically for abortion services, this legislation serves as a critical step in our state's commitment to the enshrined abortion rights and uplifts the most impacted by systemic inequities, and also strengthens maternal health outcomes for marginalized communities. I strongly urge the favorable passage of this vital legislation. Thank you.
Thank you so much, and thank you for abiding by the 2 minutes. We're so grateful. Next, please.
Okay. Thank you, and thank you for allowing us to speak today. Good afternoon. My name is Karen Nelson. I'm the President and CEO of Planned Parenthood of Maryland. I respectfully request that the committee vote favorably on this legislation. As you know, abortion services are an essential part of sexual and reproductive health care services, and as been said, 3/4 of Marylanders do agree with this as they came together last year to pass last year's ballot measure. However, as has also been said, we are living in a time that presents very unique obstacles for abortion providers such as Planned Parenthood. And more concerning, there are obstacles for those seeking abortion services. As the head of Planned Parenthood, I see these obstacles every single day, and with the stakes so high and the threats so great, we really would rely on this fund to help mitigate more tangible risk to the care for the patients and the providers, thereby strengthening the access to this vital healthcare system. Even in states like Maryland, where abortion is protected, there are still very real issues with accessing care, especially for our most vulnerable populations. We still have a majority of counties in Maryland that do not have an abortion provider, and providers are leaving the field. It is exceptionally challenging for patients across the board. The uncertainty of abortion rights at the national level also extends to the providers across the state. And uncompensated care further strains on everyone, but especially the nonprofit and small independent private abortion providers. So having this fund would limit the stress that's put on providers and, most importantly, the patients themselves, as 90% of all money would go towards that care, direct care. It would make available financial resources to ensure that the abortion care Marylanders want remains accessible. This is an extraordinary opportunity for Maryland to continue in its leadership position for reproductive health care, and thank you. We urge a favorable report.
Next, please.
Hello, my name is Lynn McCann. I'm here from the Baltimore Abortion Fund. We are a state-based nonprofit that helps Maryland residents and patients pay for the cost of their abortion, as well as travel, childcare, and other logistical costs. I spoke with this committee last year to implore the House to pass legislation creating this grant program, stressing both rising demand and cost. I wish I was back here with better news, but unfortunately I'm here to report that things have gotten worse for our organization and for our clients. Requests for assistance have continued to skyrocket from both Maryland residents and those traveling for out of care. Maryland residents currently make up about 2/3 of the clients that we serve in any given year. Our organization simply does not have the resources to keep up with this demand, even in collaboration with other partners. We estimate that we'd need at least $6 to $7 million to fully fund the cost of everyone's care and logistical support. We have a budget of about $2 million. So what that means is because funding is so limited, our helpline is forced to operate on a fixed budget to ensure that support is available year-round. That budget used to reset monthly last year. We're now operating week to week. And often our funds are exhausted within 24 to 48 hours, leaving hundreds of Maryland residents and patients with few, if any, other alternatives. We've been turning away more people every year, and even for the clients that are receiving support from BAF, they're getting just a fraction of what they need and the total cost of their care. We have patients and clients sitting in waiting rooms across the state hoping at the last minute, the 11th hour, that BAF will come through and close their funding gap so that they can be seen, especially for later care clients. And our case managers have to tell them, I'm sorry, we don't have enough. The best that we can do is give you a ride home or buy a plane ticket so that you can get back. For later care clients, that means they're often remaining pregnant and forced to give birth against their will. It is sickening that this is happening, and it is happening with increasing frequency. This is a real opportunity for us to put our values into action as a community, and it needs to happen at the state level. So we really, truly urge a favorable report on HB 930 and hope that you can do everything you can to take it across the finish line. Thank you.
Thank you. We appreciate you. So I'm going to open it up now for questions of the panel. Are there any questions from the committee for this panel? Okay, no questions. Are you surprised? You're like, oh.
Delighted.
But is it your first time here? Whose first time is it testifying in HGO? We were about to, brace our hands. No, it's okay. Thank you so much for being with us, okay? We really appreciate you. We're going to go next to Judy Carbone. Actually, because that was favorable, let me go to an unfavorable panel, okay? Just to be balanced. May I please have Jonathan Alexander from the Maryland Family Institute, Paul McCuspy, Laura Bugley, and one virtual, Michael New. Will you be so kind and bring the person up too? Excuse me? They're not on the waiting room, so let the record reflect that I call Michael New from Charlotte Lozier Institute, and that person was not on. Hi, Laura, how are you?
I'm doing well, Madam
Good,
Chair. How are
haven't seen you
you?
in a while. Would you like to get started?
Thank you, Madam Chair and members of the committee. I'm Laura Bogley, Executive Director of Maryland Right to Life. And we strongly oppose this bill that would require that insurance premiums be used to establish an abortion grant program to empower abortionists to abort more poor children. The bill targets poor and underinsured women for abortion, as the abortion industry has done since its inception, to reduce the growth in poor and minority populations. Nearly 3 in 4 women say they did not choose to have abortions, but felt pressured or coerced into the decision. Economic challenges are a major contributing factor. The state is actively engaging in abortion coercion because it prioritizes abortion funding while depriving women equal access to life-saving alternatives to abortion. If the state really trusts women to decide, then bring these pro-life bills to a vote and give women real choices. The multi-billion-dollar abortion industry does not need or deserve more public funding. Last year alone, Maryland taxpayers were forced to pay nearly $33 million for abortion purposes when we have a $3 billion deficit. We suspect that many millions more were spent but not reported. While this bill uses insurance premiums to create this additional abortion grant fund, we object to the state compelling most private insurance companies to fully fund abortion. As a result, all insurance ratepayers are being forced to subsidize the abortion industry. This not only increases healthcare costs for all of us, in my case, we've seen our home healthcare increase by 400%. This not only increases healthcare for all, again, it also infringes on our First Amendment freedoms, including our rights of conscience and the free exercise of religion. As an ethical consideration, I would suggest that any legislator who has a financial interest in any abortion organization, if you serve on a board, if you are staff for an abortion organization, if your spouse or another family member has a paid board position, to abstain from voting on this bill, and we urge your unfavorable report. Thank you.
Next, please. Thank you.
Good afternoon, Chair and members of the committee. My name is Paul McCosby, and I am here today also to oppose this proposal to establish a new program of abortion funding in the state of Maryland. Funding abortion is morally wrong. In particular, apart from the inherent act of harm to the child, it also burdens the rest of the population, particularly those who oppose it on moral and spiritual grounds, with a constant pollution of moral hazard in all of their involvement, in this case, with the insurance industry. Now, considering the amount that we've been told about underinsurance, deterring people from involvement with the insurance industry is undesirable, apparently, in that respect. But also, there is no reason to think that this will actually be beneficial. We do not have any reason to believe that, for instance, the requirement of 98% appropriated funds be distributed in grants to abortion providers. This means that the state is, in effect, abandoning a position of neutrality altogether and taking abortion as the goal. Particularly concerning, given that the risks posed by communications from insurance carriers favors helping minors obtain abortion without informing their parents. So I urge an unfavorable report. Thank you.
Thank you for being here with us. Will you Good afternoon, sir. How are you?
Good afternoon, ma'am. My name is Jonathan Alexander. I'm Legislative Counsel for the Maryland Family Institute, and I'm here to oppose the so-called abortion grant program. You know, there was a phrase that was more commonly used in our culture. It's not often used anymore, but it's a phrase that says, what you win them with is what you win them for. What you win them with is what you win them for. It basically means the tools that you use to draw someone in creates an expectation of behavior from them. So what are the expectations of behavior that we're creating by establishing a grant program for abortions? And I hope you view this in a negative sense. Grants are otherwise meant to build up communities and not tear them down. But under HB 930, we're not funding life, we're not funding healthcare, we're not funding school opportunity, we're funding abortionists and death factories. This bill does not serve the people of Maryland. It only serves to subsidize the abortion industry at the expense of taxpayers. If you're an abortionist in this state, you're getting now a no-holds-bar permanent funding stream, regardless of how the culture changes on the subject, regardless if the money is coming from hardworking Marylanders. Many of them have conscience objections to their money being used to fund abortions. But what's more insidious is the allocations that it gives to minors who get abortions outside of their parents' insurance. That does not benefit the young girls in that situation. It benefits the pimps or the predators, the boyfriends, sometimes the uncles that are rushing that girl to make a lifelong decision outside of her parents' knowledge. What you win them with is what you win them for. An abortion kills an innocent baby and destroys a life. For this reason, I urge you to reject this culture of death in our state by giving this bill an unfavorable report.
Thank you all for being here. I'm going to open it up for questions now. Are there any questions from this panel? Vice Chair Collison.
Thank you, Madam Chair. Can you tell me where you think these funds are coming from? You've mentioned taxpayers a couple of times. You've mentioned government money a couple of times. Where do you think these funds are coming from?
One person.
As described by the sponsor, the fund that was created was a dollar match program from the Affordable Care Act, the federal program, taxpayer dollars. So that's where the money is coming from. Maryland contributing through federal income taxes to the pot that is then given to the individual state. There's also mention of Medicare funding. There's also mention of other programs that ultimately do rely on excess funds that it's collected by the state and it's spread across this pool. So as attenuated as it is, the original grantees of this program are Maryland taxpayers, either through their federal funds or in some cases, the Maryland state income tax.
May I? Yes. Okay, so I need to be absolutely clear because you've made some accusations about where the money is coming from and it's not. The reason there is that assessment on insurance companies is because it was put on, that $1 per member per month was put on by the federal legislature on the ACA. It was not originally in the bill. It was amended into the bill, and it was specifically for the purpose of abortion care. That was it. The insurance companies were required to collect this money, put it in a separate fund, which they cannot spend for anything else. And that money has been sitting there for 15 years collecting interest. So are taxpayers paying insurance premiums? Yes. So if you want to make that, that's a pretty long leap between paying my insurance premium and this fund. There is no mention of any other government funds in this bill. It is simply absolutely focused and restricted to the money that is collected as the result of the amendment to the ACA, and the insurance companies cannot spend it. They are absolutely prohibited from spending it on anything except abortion care. So I need to be clear for the record where this money is coming from.
Delegate Schillinger.
Thank you, Madam Chair. Mr. Alexander, I'd ask you to comment on this abortion fund. How would you feel about dedicating some of that to helping women who choose not to have an abortion? Do you think that would be a good use?
Yeah, I heard the mention from the sponsor panel of women leaving without real choices or other alternatives. You know, one situation that you can think of occurring then is that child being brought forward into this world, that child reaching the age of 9 months, and that mother giving birth to that child. So that's an alternative that was almost hinted at in the sponsor panel. So certainly if there is a pool of money that is there, helping that mother in the first few years of caring for that child, diapers, formula, strollers, even maternal counseling, post-maternal care or postpartum care are all ways that the state can help come alongside that mother and give her a real choice, give her a real alternative. I mean, the numbers are striking. Many women say upwards of 67% that if their situation was different, they would have not had that abortion if their situation was different. So having some of that grant money that is sitting there, attenuated from taxpayers, but comes from taxpayers, having some of that grant money be used to help give women true choices and make it easier for them to raise their newborns is, I think, a very valid way that we should be using our taxpayer funds.
Thank you.
All right, I don't see any other questions. Thank you so much for your testimony today. We really appreciate it. Is Michael New there? Again, I'll give him another opportunity. He's not. All right, let's go to the witnesses that we have left. Judy A. Carbone, Donna Kaufman, Nailesh Kalanarama, Dr. K, Ernice Williams, and Jasmine Clemens. Again, Ernice Williams, Dr. K, Donna Kaufman, Judy Carbone. Is there someone that signed up that did not get called? All right, we have everyone. Good afternoon. What is your name? What's your name?
Christopher Ames.
Christopher, you're not, you did not sign in. You're not on the list. You did not sign in. Did you submit your, you signed up for testimony?
Signed up for testimony, yes.
Yesterday, it is late. It's supposed to be 2 days before. Can you go ahead and give me your testimony, please?
Thank you. My name is Judy Carbone, founding board member of the Mountain Maryland Alliance for Reproductive Freedom, with members from Garrett and Allegheny counties. It is not true that the citizens of westernmost counties are staunchly against abortion. Yes, in this past election, Garrett was the only county in the state that voted against reproductive rights to the state constitution. However, the vote was 46% in favor of the amendment. That is an 83% increase in the pro-choice vote in Garrett from the 1992 state abortion referendum. The majority of Allegheny voters approved the amendment. We have some of the highest poverty rates in the state, with Allegheny median household income at 43% below state average, and Garrett's at 38% below state average. Until June 2023, Mountain Maryland was also an abortion care desert. Pregnant people in both Mountain Maryland counties were often referred to their crisis pregnancy centers, which are not health care providers and do not provide neutral, fact-based information about reproductive options. For desperate women, it was often the only option, regardless of their health, religious affiliation, and socioeconomic status. Then, the Women's Health Center of Maryland opened its doors just outside of Cumberland, and Mountain Marylanders now have the first healthcare facility offering the full range of factual, compassionate, quality reproductive healthcare services, including medication and procedural abortion. As an independent clinic in an impoverished area, the Women's Health Center relies heavily on abortion fund grants from across the country. But abortion funds have significantly reduced funding for direct patient care. This places an overwhelming financial strain on independent, nonprofit clinics that operate with razor-thin financial margins. Despite these challenges, the Women's Health Center is committed to ensuring that no patient is turned away and keeping costs as low as possible to serve our most marginalized community members. To do so, it is pledged to seek donations to increase patient care funding by 15% more than last year, but this level of support is unsustainable. For these reasons, and to keep our wonderful health center open, the board and members of Mountain Maryland Alliance for Reproductive Freedom urge this committee to vote favorably on HB 930. Thank you.
Good afternoon, Madam Chair, Vice Chair. For the record, my name is Jasmine Clemens. I'm here on behalf of the Comptroller of Maryland, who regretfully couldn't attend. We stand in favor of this legislation to expand access to reproductive health care services for all Maryland women. HB 930 presents a thoughtful and critical response to the growing need for accessible, affordable, and equitable abortion care. This legislation is especially important now, and Maryland must continue to be a safe haven for women who seek control over their bodies and their reproductive rights. This grant program is designed to provide financial assistance to eligible organizations to deliver essential services to individuals who are uninsured, underinsured, or otherwise unable to afford care. The bill ensures that funds are used in a transparent way with clear guidelines on how the grants will be allocated. The approach to the funding model for the Public Health Abortion Grant Program Fund, established from insurance premium contributions, is a sustainable model that supports ongoing access to care without placing a strain on the state's budget. By leveraging funds that would otherwise be underutilized, we are making a smart, responsible investment in the health of our residents by ensuring that these critical services remain available. For all these reasons, we strongly urge the committee to give a favorable report to HB 930. It will make a meaningful difference in the lives of Maryland women and demonstrates our state's ongoing commitment to equity, healthcare access, and reproductive freedom. Thank you.
Good afternoon, Chair Pena-Melnick and members of the HGO Committee. For the record, I'm Dr. Nilesh Kalyana-Raman, Deputy Secretary for Public Health at the Maryland Department of Health, here to testify in support of HB 930. Last year, the department made its first goal for its Women's Health Action Plan to protect reproductive rights and expand access to reproductive health services. We've made a lot of progress on this. We have stood up an abortion training fund, but despite this, we also know that many Marylanders struggle to get access to abortion care because they struggle to afford the costs. Insurance oftentimes covers most, but not all, and then of course there are some people who do not have insurance. While Maryland has certainly made strides to increase Medicaid reimbursement, this bill would allow more women to be able to access funding to be able to cover all the costs that they need. Since the beginning of the Moore-Miller administration, the department has worked closely with abortion providers and stakeholders to develop a responsive abortion access strategy. But without this additional financial support, we can't fully meet the needs of all patients and providers in the state. And so that's why the department supports this grant program and requests that this committee return a favorable report for HB 930. Thank you.
Next, please.
Good afternoon to the chair, vice chair, and to all of the members of this honorable committee. Ernice Williams testifying on behalf of the Office of the Attorney General from the policy position related to this bill. We've heard a lot of testimony, so I don't want to labor the point, but we support House Bill 930, which will ensure Marylanders have access to abortion care services through this creative solution that is significant funding for abortion care providers. We know that it's a crisis across many counties of Maryland, even in the city of Baltimore, where there are only 5 providers. Over the last 40 years, 50% of clinics have closed, and 67% of counties in Maryland don't have access to a provider. So for us, in our office, access to abortion care is important, and without a long-term solution, we understand that abortion care funding is going to be lost, which means that access is lost. And although we have enshrined it in our Constitution, people won't be able to access that care. This bill provides a creative solution for Maryland to take the lead at maintaining equitable abortion care and access for marginalized communities. And so we urge a favorable report. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair. My name is Dana Kaufman. I'm here on behalf of 3 organizations, MedChi, the Maryland section of the American College of Obstetricians and Gynecologists, and the Maryland chapter of the American Academy of Pediatricians. You do have my written testimony. We are in strong support of this bill, and it is a high priority. But given the amount of bills and witnesses that you have, I will say me too, and we urge a favorable vote. Thank you very much.
Committee really appreciates that. Thank you. Are there any questions for this panel? Seeing none, oh yes, Delia Riley.
Thank
Sorry.
you, Madam Chair. So I don't know who would be best to answer this, maybe the Secretary. So if these grants, if this bill would pass and we would establish these grants, abortion grants, does that then alleviate the monies that we have in the current budget and the money that we give to the training centers in the budget? Does it change any of that?
These, as I understand, these funds can only be used for very specific purposes, and this bill would really allow these funds. So insurance companies right now can use these funds, but not all of them are claimed.
I get that. I
So
understand
so
what
it
the
can only
grant's
be
for.
used for this specific purpose for services.
Right, that's what this bill does. It establishes the grant fund, which I understand it can
Right.
only be used for abortion. My question is, what happens to all the funds that are currently used for abortion purposes in our budget? Does it take that away?
It does not, because the only other funds that we have is the abortion training program, and that's also very specifically can only be used for training.
Okay, thank you very much.
All right, no other questions? Thank you so much. For the gentleman, Christopher, the rules are that for anyone listening, in order to testify for the committees, you have to sign up 2 days in advance because staff has to prepare everything for us. The hours that you can sign up are 8 a.m. to 6 p.m., and you will receive a confirmation email if you were selected. If you sign up, you're going to testify. You will receive an email confirmation letting you know. You signed up yesterday, which was not on time, so you're not signed up. I'm going to allow you to give the testimony. I'm going to allow you to give the 2-minute testimony, but then I need you to go next door and give your name so that my staff can go ahead and do everything they usually do when the person signs up on time, okay? If you could give us your name and what your testimony is, please. Thank you so much.
Thank you for allowing me to testify. I did sign up. It said a deadline. I figured the deadline was the deadline.
It is a deadline. I'm stating for it's not, doesn't make no time. But go ahead and give us your testimony.
Thank you. I'll remember next time, 2 days before the deadline. My name is Christopher Anderson. I am the chairman of the Maryland Black Republican Council, and I'm asking for unfavorable response for HB 930, and I'm asking you to vote against it for the following reasons. The CDC has requested abortion data from each state to show the just cause for the need for abortions. Maryland has refused to report abortion data to the CDC. Maryland is one of 3 states that doesn't report the data for abortions for poor black women. Maryland reports data from Medicaid for reimbursements, but all the reporting we do. As of 2024, we paid $9.1 million for 12,518 abortions. That's for Medicaid reimbursements. So we don't know the actual numbers of abortions in the black community, and I'm betting it's a lot higher than these numbers that I'm reading, and we don't need funding for more of that. The mortality board rates are higher for black women. Black women suffer from mortality of children, their children dying even after abortions because their bodies are so mutilated after some abortions. In 2022, the Abortion Care Act requires insurance companies to fund abortions for poor black women. We spend $3.5 million of the taxpayers' money for abortions, to train abortions for the need for poor black women. Some of these women don't see an obstetricianist or a real doctor about their abortion needs. Taxpayer abortionists are the biggest funders for this abortion. I think this hurts the black community. I think it's eugenics at its best, and I think taxpayer money should not be funding abortions in the Maryland state at all. And that's my stance on it, and I think we should really look at it. What's really doing for poor black women is killing them off, and a lot of people don't say it. We say it's health care, but I do not think it's health care. Thank you very much.
You okay?
Thank you. Thank you very much.
You take care. Now, please go next door and provide your name so that we can have it for the record. I appreciate it. All right? We have a lot of witnesses. When you come up, if the alarm sounds, please start wrapping up, okay? This is the last witness that we have for this bill, and we are going to actually conclude the bill hearing on House Bill 930. Now we're going to House Bill 970, Delegate Woods, Health Insurance, Insulin Prohibition and Step Therapy or Fail First Protocols. Delegate Woods, will you be so kind and bring your panel? And I believe you have Monica Bilger.
Is there one other person? Oh, no.
No,
This-
you
I'm
have
sorry,
it
my
unfavorable.
error.
You don't want him with you there.
This is quite correct.
Trust me on it.
This is quite correct.
Not personally. Go ahead.
Good afternoon, Madam Chair, Madam Vice Chair, and members of this illustrious and esteemed Health and Government Operations Committee. I am Delegate Woods and presenting House Bill 970, which has the cross-file Senate Bill 646, Health Insurance, Insulin, Prohibition on Step Therapy or Fail First Protocols. This bill endeavors to This bill endeavors to prohibit Maryland insurers, nonprofit health service plans, and health maintenance organizations from imposing a step therapy or fail first protocol on insulin or certain similar medications used to treat the insured or enrollee's diabetes. This bill is necessary to ensure that Marylanders are indefinitely protected from fail-first policies, potentially harming patients and adding unnecessary complications while delaying access to the most appropriate insulin treatment options. Patients should not be obligated to just wait and see if a medication will fail before having access to potentially life-saving medication. These delays are often for several weeks, even numerous months before the initially prescribed medication is approved. Medications preferred by insurance providers have more to do with cost than care for the needs of the customers. These medications are historically and undeniably cheaper and less effective. Research shows 20%, that's 1 in 5 people who were required to fail first at a prescribed medication had to visit the emergency room or be admitted to the hospital because of this requirement. It should also be noted that side effects of fail first medications have historically contributed to irreversible disease progression. This should never occur simply because insurers don't value the quality of life over the cost of medications. And for this reason, I am asking for a favorable response to HB 970. Thank you.
Madam Chair and honorable members of the Health and Government Operations Committee, thank you. My name is Monica Bilger, and on behalf of the American Diabetes Association and over 500,000 Marylanders living with diabetes, the ADA expresses our support for Diabetes Champion Delegate Woods and House Bill 970, prohibiting imposing a step therapy or fail first protocol. The ADA commends Maryland for its strong patient-centered leadership in addressing the diabetes epidemic, and we highlight the bill sponsors, the Chair Peña-Melnick and Chair Feldman, for leading the charge in capping insulin prescription co-payments a while back. Because many patients with diabetes rely on insulin to manage their condition and prevent life-threatening complications, we want to build on current existing best practices through this important legislation. Current insurance carriers do not insist on step therapy for insulin, but there is nothing from preventing them or new carriers to implementing this practice. SB 646 ensures that providers, not insurers, will have the final say in selecting the appropriate insulin for their patients now and in future by codifying existing best practices. practices. Insulin is not a one-size-fits-all medication, and access to right insulin at the right time is critical for effective diabetes management. We have heard from folks around the country where they do have implemented step therapy, and the stories would shock you. It includes people who have gone into anaphylactic shock and still have to continue through step therapy before getting the right insulin that was prescribed for them. In a time of great uncertainty, patients deserve the stability in their care, and Maryland taxpayers deserve good policies that address healthcare costs. If carriers were to implement a step therapy, rest assured, preventable health emergencies would not only jeopardize patient health here in Maryland, but also increase healthcare costs for both patients and the system as a whole. Insulin is life-saving, and Marylanders should not be subject to potentially harmful delays in accessing the treatment that best suits their medical needs. So we respectfully request the committee for a favorable report, and thank you.
Okay. Bless you. Sorry, thank you. I don't know what it is in the air. It's making me sneeze. I'm going to open it up for questions now. Any questions? Delegate Chisholm.
Thank you, Madam Chair.
Thank you.
I'm going to assume that we really haven't had anybody with type 1 diabetes that was denied insulin, but I don't know if you would know that, Delegate, or not. And I'll ask the insurers when they come up. That is 100% not acceptable. And I'm saying it's acceptable for type 2, but type 1, insulin is the only remedy. So I would be curious to know if we find out that people with type 1 have been denied the insulin prescription, but I'm just curious if you've gotten any stories of that.
I'm going to defer.
Thank you, Delegate. So I will say at this time, there haven't been in Maryland. Now, we have heard stories. The issue is that carriers currently, in best practices with Maryland's gatekeeping ways, we aren't seeing that as much in Maryland. The issue is that we don't have this codified. So if new carriers come on board, or if insurances choose to change their practice and align with what's happening around the country, then that safety is gone for people living with diabetes.
Okay, that makes sense then. Thank you. Thank you, Madam Chair.
Delegate Chisholm. Any other questions? Seeing none, thank you so much.
Thank you.
For your leadership, Delegate. We do have an unfavorable, and that's Michael Johansson. Will you please come up? I do not want to be sitting next to you right now.
I'm going to be easy today.
Are you?
Mike
Tell me
Johansson.
how easy are you going to be?
This was real easy.
Okay.
On behalf of PCMA, the Pharmaceutical Care Management Association, first thing, PBMs only implement any of these measures at the direction of the health plan sponsor. Do we have tools that can do things like step therapy? Yes, we do. If the health plan sponsor wants them, great. For example, I think the state employees health plan has a PBM, but they haven't instructed them to do step therapy and other types of things, right? So it's the health plan sponsor's choice. On this bill in particular, I think as you heard, there really aren't fail first protocols and things like that for insulin. So it's not a problem. I understand the motivation perhaps to pass a bill. We wouldn't agree with it. But specifically, the concern is on page 3, which says you can't have a limitation on insulin or an insulin analog, and that really isn't as much of a problem as the rest of that sentence, or other prescription drug that performs a similar function to insulin, which could be a new drug like Mounjaro that's on the market that can be effective in controlling diabetes, very expensive. Some people take it for diabetes. It's very similar to the weight loss drug. So that's a particular concern. And then it says, regardless of the method of administration. So suppose an injection is safe and cost-effective and medically effective, but the inhalation is 3 times more expensive. Do you want the health plan to suggest to try one versus the other to save everybody in the plan money? So we have a concern with all the language after the word analog on page 3. And I expressed this to the proponents yesterday. I'm not sure if they agree, but they agreed to change something. I guess I'll wait and see what they suggest.
So are you willing to work with the
Absolutely.
and try to come to some compromise?
Yes, Madam Chair.
All right. So Delegate Woods, as soon as he's done testifying, can you walk outside? Thank you.
Thank you.
All right. Wait a minute. Any questions? Delegate Bagnall.
Thank you, Madam Chair, and I hope that this question will inform the conversation going forward, because you mentioned that, there's a question of whether you want the carrier to be able to say, do you want to try this or this that's more expensive? And I would argue that I think the preference is for the provider to be making those recommendations. So I hope that in the spirit of ensuring that our providers have the best tools for health outcomes, that we continue the conversation on what the best path is
If a
for codifying best
provider
practices.
says that one form is medically necessary, that is a stronger statement than one, they're both equal, both medically effective, which is typically the case as far as I understand. And then the person who is doing the paying gets to make a recommendation. Well, if they're both medically effective, why don't you start with one, then the other? It's a balanced system. Someone has to have a balance. The doctors don't pay the bills.
Delegate Wagner, did you have a follow-up? Okay. No. All right, Delegate
And I'll be
Woods.
back.
And Madam Chair, I just want to ask if I don't come out with you immediately because I'm doing the delegation bill, I'll come out after that.
Okay.
Is that okay? Thank you.
Wonderful. And if I can ask you to wait for
Thank you.
her?
I'll be
Is
here
that
all day.
okay?
Yeah.
All right, great. Not a problem. Any other questions? This actually concludes this bill hearing on House Bill 370. Was that 370? 970, sorry. I crossed over it. 970. Now we're going to go to, is Delegate Miller here? Will you come over, please? Health insurance required coverage prescription weight loss drugs. And then after that, I am going to do 378, then 1045, 1082 and 1045, because I have a meeting at 5 that I have to attend, a very important meeting with leadership. So I'm going to put those two bills so I can give the testimony, and then we go back to the order. All right? So when I get up, I'm coming back, Delegate Collison, and we'll continue. Delegate Miller, how are you?
I'm doing well, thank you. How are you?
I'm doing great. Thank you for asking. Will you be so kind and give us your testimony?
I certainly will, and I get a little passionate about this subject, so if I go too long, just feel free to do a buzzer or click or something to let me know, okay?
Well,
I will try not to.
It's okay. Go ahead.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the HGO Committee. I am Delegate April Miller, and I am here to ask for your favorable report on House Bill 1031. Obesity is a public health epidemic. Obesity is a chronic and complicated disease, and as it is being left to continue, quote, unabated, represents a catastrophic failure of government policy, public health, and medicine, but not only these domains, according to Elliot Berry. Flashback for a second to the 70s and 80s. Remember when we were told that margarine was healthier than butter? When we should not eat eggs because of our cholesterol? Whole milk was bad, vegetable oil better than olive oil, and does anyone remember SnackWells? We needed everything non-fat, all carb, which was totally ultra-processed. Low-fat, sugar-free were supposed to be healthy. And of course, anyone remember trying to decode the amount of trans fats in something when we discovered how truly bad they were for us? And how long did we study a food pyramid that was actually pretty much upside down from the healthy lifestyle we need? Now, let's look at the obesity epidemic timeline. Obesity being defined as BMI greater than or equal to 30. From 1971 to 76, there was only about a 0.5% increase in the prevalence of obesity in the U.S. The prevalence in obesity in the U.S. from 1976 to 1980 was 15%, ages 20 to 74, both men and women, counting everyone across the board. Then 23.3% in 88 to 94, 30.9 in 99 to 2000, and 41.9 from 2017 to 2020. Worldwide, the obesity rate has nearly doubled since 1980. So what was going on around 1980? Is it just a coincidence that at the same time our available food products decreased in quality that consumers were encouraged to consume some of these healthier options? Our obesity rates skyrocketed. While there was an increase in sedentary leisure and lifestyles, it was also the time of increased exercise in form of jogging, aerobics, and things like that. So what else was happening? Sugar. Sugar consumption also rose at the same time as the price dropped, around 1980. There was also a huge increase in sugar-sweetened beverages consumption. I remember using a cold Coke can wrapped in foil as my ice pack for lunches on field trips. And these items were often marketed to kids. The amount of sugars in everyday products skyrocketed, including breakfast cereals that was also, again, marketed to children. Sugar and sugar-based beverages were linked to the obesity epidemic. So what do we know about sugar? It's addictive. The pleasure centers of the brain that respond in some people to sugar are the same areas that light up when an addict will try to get their fix. Ultra-processed food consumption and production also skyrocketed, and they were stripped of needed vitamins and minerals. But hey, they lasted longer on our shelves. And they were often marketed as a healthy, convenient option for now busy moms that had microwaves, if you remember getting your first microwave, and were heading into the job market at greater numbers. This was the era of latchkey kids that were often forced to make their own food and what was available and easiest. On Friday nights, when my mom would be working late at the bank, it was always a special dinner for us to go with my dad to pick out our dinner at the grocery store, and it was usually a TV dinner that I got to pick out myself, or we would head to McDonald's. The rise in the dining of fast food restaurants also occurred during this time, all factors that contributed to the obesity rates. And then don't even get me started on the Farm Bill and USDA and high fructose corn syrup. And in July 1982 was the debut of Diet Coke. And what did that do? What did all the artificial sweeteners do? They, of course, made us gain weight, but because of the artificial sweeteners that lead us to consume even more high-calorie foods and also have contributed to the obesity epidemic. So you may be thinking, this is very interesting, but what the frickin' heck does this have to do with her bill? Do you all remember another product that was addictive and sold to us as something that could be healthy and marketed to young people through advertising and also had a devastating impact on people's health and was even given to our soldiers at one point? Why are we not holding companies and even the USDA accountable for deceptive advertising, marketing to children, getting us addicted? Why do they not have to pay restitution like our cigarette manufacturers? And why couldn't we then use these funds to help mitigate the cost of this epidemic? To help provide healthy food options for our families, education for our kids, and to provide coverage for medicine that has now been proven clinically effective and will keep these individuals from progressing further into a disease state. Do we deny smokers with lung cancer's treatment? Do we not pay for medications that will help them stop smoking? Guess what? You can't just stop eating cold turkey, but you can take a medication that's prescribed by your doctor that will reduce your food cravings and give you a jump start to returning to a healthy lifestyle, to reduce levels of inflammation so that you can exercise again. Oh, and what happens to a lot of people when they stop smoking? They gain weight. I recently had a patient with diabetes who has been on a GLP-1, and she said to me that I finally feel like myself again at 51 years of age. This bill simply mandates that insurance companies offer some type of coverage of weight loss medications, FDA-approved, prescribed by their doctor for individuals who are diagnosed with obesity, along with another accompanying comorbidity, like diabetes, which is already provided, but hypertension, heart disease, high cholesterol. The insurance industry should not be allowed to further perpetuate the harm that so many in our population have fallen victim to. Obesity is an epidemic that has a clearly defined start date, and there was a resultant impact on consumer health that was heavily influenced by industry and our government. And now we are further victimizing them by withholding treatment. Oh, and did I mention all the levels of disparate impact on our communities of color and in low-income areas where there are food deserts, where most of their food is low quality and ultra-processed? Where the cost of organic meats, vegetables are out of their price range, and now we are further victimizing them by only allowing access to life-saving medication if you can pay for it. Are we going to allow this inequity to continue? Because if there is no insurance coverage at all, guess what you can't use? The manufacturer's coupon or discount that makes the medications affordable. And yes, there are side effects. Not everyone should take these medications, even though they are FDA approved. One that gives me pause is a possible connection with something called NAION, which is a non-arteritic ischemic optic neuropathy, which is an eye issue. However, have you ever seen a person go blind from diabetic retinopathy? I have. And have you ever seen a retina 360 degrees scarred by a laser with only a small island of vision left? There is risk to every medication and procedure. It is between a doctor and a patient to decide what is the best course of action for them. And for those that cost is the sole reason for not allowing a blanket restriction on an FDA-approved weight loss prescription medication, my question is, what is the true cost of the obesity epidemic in totality on the health care system, both nationally and here in Maryland? And isn't it time we stopped allowing them to not treat people who are diagnosed with a medical condition? There is a current lawsuit that's actually multiple current lawsuits being brought, including one against Cigna, for non-coverage. I have not even begun to start talking about how obese people are treated and discriminated against, even in the medical community. You know what I was told by my former cardiologist when my weight started creeping up? He said maybe I should cut down on the donuts. And notice I said former cardiologist. And he may have had a point, but his delivery was awful and it made me feel horrible. Do you think I went back there? And that's what happens to obese people all the time. And the result is that they avoid and delay care, making it even more costly when they finally seek help, even applying to mammograms and other preventative services. So you hear, why don't you hold yourself accountable? It's your fault. And I admit, I'm addicted to sugar, try to lose weight. When I finally reached out for help, because I know that I can't do this on my own, my old patterns started to take hold. I was put on a medication that helped me. It reduced my inflammation. I felt good. I was able to exercise. And then I was no longer able to get it. The cost, even for me, is out of my range, and our insurance stopped covering it. No coverage at all. Again, no coupons, could not get it. So, again, I'm here fighting. I have a voice. I have a pathway to advocate and change policy, to change perception. And you all have the power to make that change happen for the powerless. I'm not going to be ashamed of it anymore. I'm going to speak out, and I'm going to speak up for those that can't. So please vote favorably on House Bill 1380. And I apologize for taking so much time, but I could literally go on for hours, but I will save you that. But feel free to stop by the office.
It's okay. I know, I have to say, it takes a lot to come here and testify anyway, a regular person. It takes a lot to be in elected office and open yourself up as well, right? Mm-hmm. And I want to thank you for sharing your story. There's no judgment here, right? And right. I hope and wish we were less judgmental as a society. So don't justify it, don't apologize here. We respect it, okay?
Thank you, Madam Chair.
You're welcome. Delegate Hutchinson.
Thank you, Madam Chair. Thank you for letting her go on longer than normal, but that was awesome. I mean, that was, it's probably the first time in my 3 years of being here I saw somebody with such passion just sit there and tell a timeline and a story of things. And I certainly found out that the Diet Coke wasn't helping me either when your diatribe there. But I'm a little confused, and you and I talked about this bill last night when we were out. Are you asking for the carriers to pay for the drug or to put it on the formulary?
I'm asking more to just put it on the formulary. I'm not asking, and you guys have all the expertise to deal with that. All I'm literally asking for, that it is on formulary and that there's some type of coverage, because without that coverage, again, you can't use any discount, you can't use any coupons. I'm not asking them to cover at a certain level. I'm not asking anybody to cover anything in full. So, I mean, the fiscal note obviously is going to be a little crazy because of that, but that's all I'm asking for, is that we start treating this like a disease that it is, and there are options that are FDA approved and that are making incredible differences for people, and they're keeping them out of a disease state that will be for the rest of their life and make irreparable harm and changes if they don't get these things under control. So why do we wait? Why would we wait for someone to become diabetic before we would offer these things that could actually prevent that? Why do we have to wait for them to be in severe disease state for them to be able to have access? So it doesn't make sense. So, but I'm not asking for complete coverage. I understand the fiscal situation and the fiscal realities that these expensive medications have. But the healthcare cost going down the line of treating these epidemics and what people are up against is what we really need to be fighting for. And, you know, again, it's not full coverage. It's just something on the formulary.
I just need a clarification. So I did ask if you are asking them to cover, but you're sort of using that word coverage in your.
Yeah, I know, and I don't know if I'm using it right. I mean, maybe you guys are the ex. I use it as not cover payment, but just have it on formulary where it is.
And the
on
benefit
the
of being on the formulary without you getting that would be what?
The benefit of it being on the formulary, even if the copay was high, that you could use a coupon that would then take that prescription cost down from the manufacturer, that would then take that prescription cost down. If we could put, I mean, I would love it if we could have it on formulary and still have a high, at least a deductible or something that's reasonable because of the high cost of these medications. That would be great. But I understand what I'm asking for, but we have to start treating this like a disease and giving this aspect and stop the discrimination.
And just to follow up on that, I know Delegate Shalega is next. What you're asking for is that right now, they don't cover it, period, unless you meet certain requirements.
Right.
And if you look at the Maryland Department of Health letter, it says that Wegovy, which is one of the drugs, is eligible under the State Employee and Retiree Health and Welfare Benefit Program, but only for those that, for example, have had a heart attack, a stroke, or and be obese, meaning you have to have the heart attack, you have to be obese. And it's interesting you say that because right here, I'm holding a denial for a person who is under the state plan, the Med Impact. So we have a new state plan.
Yeah.
And I actually heard from 4 other colleagues whose drugs have been denied. It's not even covered, that have been actually receiving their drugs covered under the old plan, CVS.
Yes.
The new PBM, I'm actually collecting them for those of you that have denials.
I'll get you one.
I have quite a few already in my purse.
I'll get you.
I'm not kidding you.
I know.
Because I wanted to talk to HR about it. So this is one person who is in her 20s, who is obese, whose doctor recommended that she go on Wegovy. They said no. She appealed it. This is the appeal. This is like 6 or 7 letters.
Which takes so much
pages.
time.
And it says you can only get it if you have had a heart attack. But she is going to get there because she's pre-diabetic.
You got it.
So it makes sense to cover it. And even if it cover it where she pays $500 or $200, pay something. Not the whole enchilada.
Right.
But those of you that have these, give them to me. All right?
Yes, ma'am.
So I get you 100%.
Yes.
The problem is, I support this bill. Is the fiscal note says that it will cost millions of dollars.
I know.
To the state health plan. So when we have this fiscal note in the fiscal condition we're in, it is difficult to pass this bill. Is it the right thing to do? Yes. But it's the money. But can our plan negotiate with the PBM, who one of their lobbyists is right behind you? This is the problem that we have. Can we negotiate and include it? Because this is a problem.
And that's what I would want to know, if what the fiscal note is reflecting. Is it reflecting that I'm asking to cover it 100%? Or is it reflecting, like you said, where it would be on a formulary where it is at $500, or if it is at $700 for a copay? That's a whole vast difference on what a fiscal note would look like. So, I looking into that option, but 100%, why would you not cover it when she was obese and if she had hypertension? Why would you wait till she has a heart attack or a stroke?
Yeah, it makes no sense. So I have been collecting it because I wasn't sure what I was gonna do, but I think I understand now what I'm going to do. So if you have them, give them to me. Delegate Shalega.
I think you opened the floodgates, Madam Chair. You'll probably get boxes of them.
I want them, you know why? Because this is a contract and this is a new
Right.
company. And we didn't have this problem with the prior one. And the prior one was able to make a business, right? The state was doing fine with it. But this is not right when our colleagues' medications are being denied now. Like, it's not even you have to pay $50. It's like we don't cover it, period.
Right.
Yep.
Go ahead,
Or
Delegate
switching
Szeliga.
a medication. So my question is this. First, I want to point out that the fiscal note, thank you for your testimony. It was excellent. I love your summary of where we've been with all that. What was that? Those foods, Snackwells? that
Snackwells. You guys
tasted
don't remember
like
Snackwells and the
cardboard, and they're
green
like,
bo-
this is good for
Yes,
you?
yes.
Yeah, I
Mhm.
was there.
Yep.
So it says, to the extent that anti-obesity medications reduce obesity rates, there may be long-term reductions in program spending on chronic diseases. Exactly what you said. If we can make America healthy again, if we can make Maryland healthy again and get off all of these terrible foods that you talked about and bring weight down, you know, they can't tell you how much the state would save in healthcare costs. But my question, you may not be able to answer it. We may have to wait for the next panel. So with these weight loss drugs, there are like compounded, like
Yes.
GLPs
Yes.
that people can get.
Yes.
That actually Ryan Araki, Delegate Araki's wife, is functional nurse practitioner that
Yes.
prescribes these. They're much less.
Yes.
Why can't these, pharmacy plans include these other exactly same thing that's a fraction of the price?
My perspective on that, right, that's a question for that, as far as the, why can't they include? I'm not sure, like, when I start talking PBMs and pharmacy, bless you people for what you do with this, because it's really, really confusing. But I thank you for asking about the compounded part, because my worry is that there are going to be bad actors that aren't a trusted pharmacist or some kind of trusted place where they get the medicines compounded. What if they're getting them like not in a good place, or there's like a black market, or there's something that would be harmful? And I don't know. I haven't researched or seen any status of that. But when we talk about compound medications, that's a very specific process that has to be followed. And so if you are using something, a place that's reputable, or pharmacist that's reputable, that's one thing. But my worry is then, does that incentivize anything as far as like a black market for these, because they are so popular and people are desperate to get them? But I get that would be probably more of a question for them of why they can't, or why they can't
bring the
use the
cost
compounded,
down.
right? Especially, that gets into a lot of, generics, and are generics available, and, we're,
And
the
maybe
timeline
it's
of that.
we'll ask.
It could be
Maybe it's a
proprietary.
trademark
Yep.
issue and they haven't been on the market long enough to be
do it.
generic. Okay,
Right.
Thank you.
I think they were doing mainly the compounding when there was a shortage, when there were shortages, so you might want to ask about that one.
Any
Sorry.
other questions? Delegate Johnson.
Thank you, Madam Chair. And Delegate, thank you for this bill. And
You're
thanks
welcome.
for coming and telling your story.
Thank you.
So do you know now, do insurance companies cover gastric bypass surgery, which is about $15,000 to $35,000,
Some
heart
do.
attack care, stroke care, bypass care, along with the post-care and treatment that go with those? Do you know if they cover those? And is that your point, that we should get more on a preventive instead of a reactive path?
100%.
Thank you very much.
You're very welcome. Thank you.
Any
Thank you
other
for the question.
questions? Delegate Riley.
Thank you, Madam Chair. So do you know, so you're on these drugs for whatever the reasoning be. So is it something that the patient would be on for a lifetime, or is there some point to where you're off of the medication? And if so, does that weight come back? Or is this something that you use it for a certain amount of time and then the weight's off and then you are that way? Now again, obviously, certain things like all those bad things you said, that cause a lot of these in some patients, obviously their eating habits will change. But is this something that will
And that is actually part of it. Like, when you are on these medications, you actually should, and I think we do need to do a better job of that. You actually do need to make sure you are still eating healthy meals, because that can increase side effects and things like that. So, and be kind of actually relearning on how you should eat and what's the best way in the combination for your body to remain healthy, and what actual, normal portion sizes. And hopefully it gets you off the addiction, and so that you no longer want the sugar or crave the sugar. You should also be doing some of the exercise, of course, strength training to build your muscles so that you don't lose muscle mass when you're losing the weight. So all of those things play into how you will do either with reducing or off. So you build up your dosage to you reach a certain point where you're losing weight, and then once you get to the point that where they want you to be, then you almost kind of go to a maintenance dose, is my understanding, or from what I've seen from my patients, is that they're kind of more on a maintenance dose. But the idea would be to go off of it, but I think it's so new, I'm not sure what the exit ramp looks like for every person. But yes, I gained weight back when I went off, because I went off before I had those things in place, and then so, yeah.
So my point too, with that, that could change the fiscal note too. So are they taking in consideration that once a person starts, they're on it for a lifetime, or are they?
That's what I don't know with the fiscal note, or are there better plans? And maybe some of, I think there was, I don't know if there was going to be other supporting testimony, but there may be others. I can get back to you on what is the current updates on exit plans or getting off the medication.
Thank you. I appreciate it
of
very much.
course.
Thank you. Thank you for
Of course.
I don't see any other questions. Thank you so much.
Thank you.
Appreciate you. Keep at it.
I'm back over at the Burfer right now. out there. Thank you, guys. Have a great day.
You're welcome. You too. Why don't we go ahead with Monica?
Yes, hi. Hi, Delegate. Yes, thank you so much, and I'm back. Madam Chair and everyone, thank you so much. Obesity accounts for up to 53% of new cases of diabetes each year in the U.S. According to NIH, over 85% of people with type 2 are overweight or obese, and moreover, obesity is the largest contributing factor to chronic disease, as we just heard. It exacerbates or causes over 200 medical disorders. But let me talk about two. The financial burden of overweight and obesity is equally compelling in supporting comprehensive treatment and providing coverage. Total cost of obesity in Maryland alone is $30.54 billion annually. That's billion. Moreover, ADA is gravely concerned about the significant increase of obesity and its compounding impact on diabetes. What does diabetes cost annually for Maryland? $7 billion annually for having individuals with diabetes. $37 billion annually if you just cover obesity and people living with diabetes. That's now not counting 198 other chronic diseases or disorders caused by obesity. So what does that cost? And multiply that. ADA's 2024 standards of care recognize that obesity is a chronic and progressive disease. There's consistent evidence that obesity management can delay the progression from prediabetes to type 2, and it's highly beneficial in treating type 2 diabetes. Obesity also disproportionately impacts communities of color and rural communities that face already systemic inequities in life and access to treatment of care. Why are we denying something that is working? I wanted to share that ADA recommends comprehensive access to and coverage of person-centered obesity treatments that includes FDA-approved medications for both short-term and long-term weight management. We strongly, because of these issues and more, encourage a favorable report for HB 1031. With regards to personal note, I too have been on this, and I just want to say, I want to thank 60 pounds later, feeling much better. And it does make a huge difference in someone's life. We owe that to everyone.
Thank you for sharing your story as well and for your advocacy. It makes a difference. Are there any questions for this witness? Seeing none, thank you so much. Let's go on to Michael Johansson. Thank you for being with us this afternoon.
Thank you, Madam Chair. I'm Mike Johansson on behalf of the Pharmaceutical Care Management Association. So first off, plan sponsors tell PBMs, plan sponsors decide what is covered. Plan sponsors can also say, it's covered when, such as what conditions is it covered? And then finally, plan sponsors make the decision on the tier or the copay and the cost sharing. So in the current state employees plan, DBM either acknowledged that there was a change in the criteria to get the drug, which is why there's more denials, or DBM could simply instruct the PBM to change the criteria to get the drug. It's in this plan sponsor's decision. With respect to the intriguing question from Delegate Hutchinson, there is something to the notion of putting it somewhere on the formulary so that you get the benefit of telling the PBM to go out and negotiate the best price with the pharmacy and perhaps rebates from the manufacturer. And even if you put it on the formulary with a very high cost share, typically there's a 3-tier, really low copay, make it a new tier and say you have access to this, we've negotiated the best price, but you have to pay 75% of it or a high number, something like that. Again, those are decisions the plan sponsor can make, and it would be a way to mitigate the cost. When it comes to how long you're on the drugs and did they do a good job of evaluating the cost savings, probably not. I think there is data about cost savings of taking these drugs and controlling diabetes and losing weight, but it's a little open how long you would really be on it. On the issue of in the retail market, some of the compounded drugs that are available, most of those providers, because of the complexities of insurance, don't accept insurance. So if you contact one of them, it is an available drug, it's a prescription, you have a health care, those medical decisions are made, but typically those aren't people that are using insurance to get them.
Thank you. Any questions? Delegate Szeliga, go ahead.
Thank you, Madam Chair. So are you not the right person to ask about why they can't put compounded? Why do they have to use the Wegovy? I have no idea whether it's that one or one of the other ones that's the semi-glutide compounded thing.
Someone was right about the availability of compounded drugs in some FDA world only exists when there's a shortage. And I think it was just last week, one of those products was deemed not in shortage anymore. And the folks that do the compounding have tried to stop FDA from saying there's not a shortage so that they can continue to do it. It's complicated. I maybe get a written answer for you so you have it.
Yeah, it would be interesting to know why, because we see those advertisements, you know, like Hims and Hers or what, you know, for being able to get it, and they don't call it Wegovy, they call it GLP something.
It's a compounded GLP or semaglutide,
all right,
something
that'd be
like that.
good to know. Thank you.
Thank you. Any other questions for this witness? Delegate Hutchinson.
Thank you, Madam Chair. Thank you, Michael. So is there, if it's not a situation of having it reimbursed, you know, the carrier's paying for it and it's getting it on the formulary, is there something here in this legislation, or what you're saying is we don't have to legislate this, it's really the plan sponsor going back and saying, I want this on the formulary for this purpose at no reimbursement?
At no reimbursement, meaning?
Meaning
the plan sponsor's not paying, we want the customer to pay for it.
The customer, yeah, that's correct.
They could do that now. I mean, a bill certainly encourages those plans that you regulate to do it, right? It doesn't tell the ERISA exempt plans, for example, that's a different conversation. But if you get it in the basket of things that are available, you get the benefit of a different pricing structure instead of the usual and customary price that you would go when you go to the pharmacy. And I think if there are coupons, again, it's probably easier if they get processed through the system. The other thing that's really helpful when you have something that's covered, even if the patient has to pay a lot for it, it's processed by the PBM, which then is more recognizable in your list of drugs for contraindications. Every pharmacy does a review of drug complications based on the drugs they're aware of, but the PBM knows every pharmacy that you go to. So if it gets in that list, now all of a sudden, they know if that particular drug is going to be a problem with something else you're taking. So there is a benefit for that as well.
Absolutely. All right, thank you.
Any other questions, Delegate Taveras?
Hi, and I just want to get clarity on how do you guys make a decision on what are the drugs that are going to be the most cost effective, right? Because in some of the cases, you know, they could be temporary, like some of these could be as long as you meet certain criteria. But what if you have a chronic disease where you've got to take a particular drug for life, right? And then suddenly you shut that off. You know, to me, I don't think it's fair. How do you make that call?
Yep. So coverage of like a certain class of drugs, that decision is made by the plan sponsor. When something's covered and now you're picking perhaps between drugs within the class that solve the same medical condition, typically then the PBM, which has a pharmacy and therapeutic committee, which is actually a requirement in the PBM law today, all PBMs have to have that, and it's made up of medical professionals. They can make decisions based on the efficacy of certain drugs, contraindications, step therapy recommendations, other utilization management. That's part of what that group does. They then make the recommendation back to the plan sponsor, and it could be, we recommend these practices so that you can better control the choices that are made and what you're paying for. And the plan sponsor, in some cases, the state health plan has decided they don't want some of those controls. So it's a collaborative decision, with the ultimate decision being by the plan sponsor.
Maybe you're making the case for Delegate Woods, but thank you.
Okay. Thank you very much. Any other questions? So seeing no other questions, this House Bill 1031 is actually concluded. We're going to, Delegate Woods, I'm going to go to the two bills I have because I have a 5 o'clock and it's already 4 o'clock. And then when I'm done with those two bills, then we'll call your bill, okay? So you can go talk to him now. So the order of the bills now will be House Bill 1082 followed by 1045. Then we're going to go back to the order of 1059 and so forth, okay? So first will be 1082. And if I can have those witnesses, it's actually, the panel is Michelle Everly, Vincent DeMarco, Johanna Fabian Marks, and Marie Grant. And those are the only witnesses on this bill. If you can come up, please. All right, good afternoon. So good afternoon, Vice Chair, actually Chair now since I'm testifying, Chair, and members of the committee. It is a pleasure and an honor to present to you House Bill 1082. House Bill 1082 would establish the state-based health insurance subsidies program. It would require the Maryland Health Benefit Exchange to implement the program, assisting with providing subsidy to state residents to lessen the potential impact of the reduced federal advance premium tax credit available to Marylanders after 2025. So we know there's a lot going on the federal government, and this is a bill that we want to introduce and pass just in case we need it, right? To make sure that people can afford their premiums. When Congress initially passed the American Rescue Plan Act of 2021, the ARPA, during our most vulnerable time for healthcare amid the pandemic, we were going through so much. It significantly increased the eligibility of financial assistance available through the state marketplaces. And many people took advantage of that, and they were able to get a policy. They were able to pay for it. They were able to afford it. The Maryland Health Benefit Exchange data speaks for itself. It illustrates the impact of these federal tax credits on Maryland residents. And let me tell you why. Enrollment in the health insurance plan surged by over 50% from pre-ARPA figures to a record height of 247,000 people. 247,000 people that now have insurance. Furthermore, our health equity goals were positively affected. Those groups that usually did not have insurance, people of color, the Hispanic Marylanders, they increased by over 20% in buying insurance. Congress extended these enhancement federal tax credit through 2025. They actually, if I'm not mistaken, Michelle, they actually, we have it until December, I believe, of this year. So we don't know what's going to happen. We don't know whether they will be extended, and we have no assurances. It's very difficult to follow with all the chaos that's going on in this country right now. So allowing both new and existing insured Marylanders to continue receiving these life-changing federal subsidies, you know, we have been allowed to do that during this period. However, these enhanced subsidies will soon expire, and it will put over 190,000 Marylanders at risk of losing some or all of their financial support for their health plans. And it will push many of them to leave and not be able to afford it. 190,000. Accordingly, with the risk of enrollment losses, health insurance premiums stand to increase for the most vulnerable insured, including the elderly, the disabled, and chronically ill people. House Bill 1082 will serve as a lifeline in 2026 to our most vulnerable Marylanders. You know, the goal in this committee has been to reduce the number of uninsured. And we can argue about the premiums, but the numbers don't lie, that we have been able to reduce the number of uninsured from 14% to 6%. And that in all 23 counties in Baltimore City, people have insurance. And that they look like people like all of us in this room. And this is just another tool in the toolbox. And I ask that we pass House Bill 1082. I'm going to go now to the panel. Ms. Everly, would you like to get started, please?
Good afternoon, Chair Pena Melnick and committee members. For the record, Michelle Eberly, Executive Director, Maryland Health Benefit Exchange. I'm here today to speak to the impact on exchange enrollees if current healthcare federal tax credits are reduced. I have provided written testimony, so I will speak briefly about the need for this bill. The federal government allows Americans to claim tax credits for many things: childcare, education, retirement, appliances, capital gains, and health care. Healthcare tax credits are allowed to be taken in advance to pay monthly health insurance premiums and are reconciled when taxes are filed. In 2021 and again in 2022, Congress expanded healthcare tax credits. The expanded tax credits will be eliminated if Congress does not take action to continue them beyond 2025. The loss of these tax credits will increase monthly premiums by 68% for an additional premium and tax burden of over $820 per person, or about $3,000 per average family. Without knowing how Congress will act when the federal requirement that we have to get renewal notices mailed by November 1st, there's no certainty that the health insurance premiums will not spike significantly in 2026. HB 1082 allows the existing state reinsurance program, if needed, and I emphasize that, if needed, to fund a state premium subsidy to mitigate the significant premium increase. Not only will this provide coverage continuity and individual market stability, but it will give the nearly 250,000 Marylanders who have purchased their own health insurance peace of mind. For these reasons, we ask for your favorable reading of House Bill 1082.
Thank you very much. Who will be next, please?
Madam Chair, Madam Vice Chair Marie Grant, on behalf of the Maryland Insurance Administration, here supporting this important legislation. I think as you and Ms. Eberly have mentioned, we're really concerned about the impact that the loss of these subsidies will have on our market for 2026. And so the timeline that we need to start providing assurances is carriers file their rates with us in May. we've already asked them when they do that to provide 2 sets of rates, one with, one without. And to allow the exchange some flexibility to design a subsidy to help mitigate the loss of these subsidies, given the uncertainty on the federal level, is just going to be critical to preserving our market and the gains that we've been able to make over the past several years in terms of coverage. I just want to emphasize too, I think the language in the bill, and we're going to work with the exchange on a couple of amendments. Anywhere we don't see flexibility, we'll ask for that, because we also want to make sure that reinsurance funds are available through the end of the waiver period, and that we are balancing market stability in that sense as well. So with that, we are very much in support of this bill and happy to answer any questions.
I want to thank you for working with me, both of you, on making sure that it's drafted properly and that there is flexibility. Thank you. Next, please.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. We at the Maryland Healthcare for All Coalition, I'm Vincent DeMarco, the president, strongly support House Bill 1082. Thank you so much for putting the bill in. We are in desperate times. If these tax credits are cut, as you say so eloquently, many people will be hurt. In addition, as a report we submitted to this committee done by health economist Steve Port shows, that drop from 14% to 6% on uninsured also reduced uncompensated care by $400 million. $400 million, which would have increased people's premiums. So we all benefited by that drop in the uninsured. And if we go backwards, not only will those uninsured people suffer, but all of us will suffer. So we strongly support this bill, and I'm here to say, Madam Chair, Madam Vice Chair, we at Healthcare for All Coalition are prepared to do anything you need to help get this bill passed and implemented. Anything you need, just ask us, and thank you for all your leadership.
I'm going to open it up for questions now from the committee. Delegate Rosenberg.
I'm still a rookie when it comes to the insurance aspect of this committee. So how does having insurance, whether it is through, especially for a family that gets it because of Medicaid, what difference, given our all-payer system at the hospital level, what difference does having insurance make to a typical family that gets insurance because of a subsidy through Medicare or whatever the case may be?
Okay.
Go ahead.
I'd be happy to answer that. So the all-payer model for hospitals affects the rate setting, the amount people pay at hospitals, completely separate and distinct from health insurance. So health insurance, as you know, we all have health insurance through most of us have it through the state as state employees, and it allows contribution towards covering that cost of health care. So for instance, I go to see my primary care doctor. Actually, I think my copay might be $5, but the health insurance, the insurance is paying the $140 that the provider needs to cover their expenses for that visit. So that's how insurance works. It also allows, if you have any high, well, let's say a chronic condition where you have congestive heart failure and you might have a heart attack, and that going in and having treatment for that heart attack would be $50,000, $60,000 in ongoing costs. I wouldn't have to pay for that myself, the $50,000 or $60,000. I would pay towards that, but all the premiums everyone is putting in towards insurance is going to help that cost. So without health insurance, it's like not having homeowners insurance or car insurance. You're 100% on the hook for paying for your health care. Now, what has happened with the Affordable Care Act, and we tell people all the time through the exchange, it's no longer just catastrophic health coverage to prevent you from going into bankruptcy. There's so many services that are pre-deductible, zero cost for mammograms, for colonoscopies, for vaccinations, things as you've heard today in other testimony to keep you healthy to prevent those conditions. And in Maryland, I think I've shared with this committee before, there was a study done out of Howard University that looked at pre-ACA and post-ACA For diabetes, the amount of revascularizations for diabetics have significantly gone up, and the amount of amputations have significantly gone down, and that was having access to health insurance.
Thank you.
Any other questions for this panel? Delegate Shalega.
Thank you. I'm reading the bill and the fiscal note, and I'm having trouble sorting out how we're going to pay for it.
Absolutely. And I think you have other materials before this committee that has the reinsurance fund, and it shows the reinsurance fund through 2028. Right now, even without those expanded tax credits, we know that we will have solvency through 2028. Am I correct on that?
Yes.
Okay,
Yes. And
so
we're in
I think.
state-only funds.
Within state-only funds. The end of that 2028, we'd have 200, I believe it was like 238,000 that would remain.
238 million.
Million, sorry, 238 million that would remain. So there's funding there that we could pull some of that out and still protect the solvency of the program. That's what we're going to look at, and I think as Commissioner Grant said, we will look at, it would be at 100% or maybe 90%, but so that we could keep the market stabilized and not jeopardize that waiver. Now, that waiver today is only good through 2028. We will be coming back in 2027 to say, okay, what do we as a state, how are we going to handle this moving forward? But we have absolutely no idea what's going to happen out of the federal government, so who knows? But at least this will give our state some individual market stability through next year, through 2026, and we'll see how through
27.
Yeah.
So it's paid through a tax on insured and a provider
paid-
fee.
so the
Both of those, I
the-
saw both of those in the
Okay.
fiscal note.
So the reinsurance fund is paid for two ways. We get a lot of pass-through federal funding that comes through. That's the 1332 waiver that allows us to get funding. Now, for the first, 5 years of that, we received so much money from the federal government, we didn't have to tap into ours, and I'll talk about ours. Part of the requirement of the federal government for this waiver is that you have to put up state funding. So you can't get the program without putting up state funding. The very first year, there had been a 2.75% assessment that carriers were paying to the federal government. That was stopped temporarily. It was stopped. And so that year, we had said, well, let's take that 275, and I'll give credit where credit is due. I believe it was Chuck Burrell at Care First that said, well, let's take that we'll pay that. So it was at 2.75 that we used that first year. And then subsequent to that, we reduced it to 1% because we said, well, that will do. That will do with what we need. Let's just do it at 1%. Now, the federal government permanently waived that 2.75% for carriers. So the carriers are already up, they're only paying 1%, where they used to pay the federal government at 2.75%. That 1% does get tacked on to your insurance. I mean, just like, anything you buy a can of soda pop, you got an assessment on that for whatever. This is in the premium. It does get paid as part of the premium, but the benefit of that is everybody's premium is then down significantly, and in the first 3 years, it was down 30%. We still have the lowest bronze and gold plans in the nation. So you may be paying that little bit more for this fund, but the benefit is everybody's premiums are down significantly.
Thank you.
Any other questions? Seeing none, thank you so much for your testimony. I appreciate it. Next, I'm going to, that's it for this bill. So this concludes the bill hearing on House Bill 1082, and I know you're going to continue to work on those amendments and work with our analyst, Ms. Simpson. So we have Delegate Fair, I know you're here. We're going to go after this bill. We'll call you, okay? Thank you. I have a meeting at 5 I'm trying to make. Thank you so much. So next we have House Bill 1045, Health Insurance and Family Planning Services, Consumer Protections Updates. May I please have Dr. Kay, Karen Nelson, Marie Grant, and may I have Robin Elliott? Okay. So, Madam Vice Chair, actually now, and distinguished Health and Government Operations Committee, I want to thank you for letting me introduce to you House Bill 1045. And House Bill 1045 is titled Health Insurance and Family Planning Services, Consumer Protections. What is this bill? This bill is a forward-looking bill that ensures that our ability to protect consumers and continue to provide health care access across all levels to all Marylanders residents takes place, no matter what happens at the state level. This is another bill that we're trying to get ahead of it, prepare. Have we done this before? Yes. We did this before in House Bill 959, Senate Bill 872 in 2020. And it was titled Health Insurance Consumer Protections. And this was sort of a similar situation where we didn't know what the federal government was going to do, so we put that bill in place. At that time, that bill enshrined into Maryland law, for the lack of a better word, that you can leave on your insurance policy a child until the age of 26. So if the federal government got rid of it, it will still be required in Maryland. The insurance carriers have been paying for it anyway, right? The sky has not fallen. People are covered. And we want to be ready, and we want to protect every single Marylander. What else did we do in 2020? We said, if the federal government gets rid, and we don't know what's going to happen with all the chaos, right? With the ACA, they're probably going to take that on next. If they get rid of the provision that says that you cannot discriminate for pre-existing conditions, we will still require that in Maryland law. We also did some provisions that set standards for plans to include prescription drug benefits. We allow insurance companies to offer catastrophic plans to individuals under 30 or those with hardship exemptions. We prohibit insurers from charging higher premiums based on health status, gender, and other discriminatory factors, and many, many other things. So what I did was, a week before session, I decided to bring the Maryland Insurance Administration. I know you guys are sick of getting my calls. The Maryland Health Benefit Exchange, the carriers, Matt Chantilano, the 9 MCOs under Medicaid, the Secretary of Health, the Maryland Health Benefit Exchange, right? Everyone to the table. And I said, what can we do to protect ourselves? We did this in 2020, and I have to say, Lisa Simpson did a lot of that work. She did that work, and you did an excellent job. I'm very proud of the work we did. So what else is there that we need to address? So basically, this is it right here. This is one of them. So we have seen firsthand how shifting federal policy can destabilize healthcare access. The 2019 Title X restrictions forced clinics across the country to close or scale back services, stripping millions of people, particularly low-income and uninsured individuals, of vital reproductive health care, which is so important. At that time, participating clinics dropped from 3,954 clinics to 3,031 clinics in just 2 years. Now, I want you to think what happens to those neighborhoods and counties where that happens. It leaves a void, right? What are people to do? At that time, participating clinics struggle because of the attacks at the federal level. And that left 2.4 million Americans without access to essential care. Planned Parenthood, which served over 40% of the Title X patients, was forced to exit the program entirely and say, we're not taking the funds. And 6 states lost all their Title X funding. While these policies were blocked by litigation, we know that policy swings at the federal level are unpredictable, especially right now. So we must act to prevent another crisis that would unfold in the future. House Bill 1045 ensures that Maryland does not have to wait and react. Instead, we take proactive steps to safeguard family planning services by ensuring that if federal funding is restricted again, Maryland providers will have state support to continue delivering this essential care, which is so important for our people in Maryland. This provision is critical because studies show that Title X funding clinics relied on these grants for approximately 19% of their operations. Specifically, House Bill 1045 updates our definitions of family planning providers to protect those that may lose that federal funding due to service restrictions or referral policies. It aligns our state regulations with federal standard as of December 31st, 2024. The bill also grants our insurance commissioner new authority to implement strong anti-discrimination protections through regulations and creates a more coordinated system between our insurance commissioner, between the Commission on Civil Rights to hold insurers accountable. Furthermore, the bill modernizes the health insurance protection by embedding stronger consumer safeguards into our Maryland laws. You know, history has shown us that the risk of waiting to react is really difficult, right? That it's difficult to anticipate what's going to happen next, what shoe is going to drop next. And this bill allows us to deal with the ripple effects of these healthcare disruptions that are going to come, because it's not if they're going to come, it is when they're going to come, and for us to be ready. Without these protections that we have in this bill, we risk watching the scenario unfold again, and it will leave us vulnerable. And why do we want to do that when we can prepare and we can get ready? And so therefore, I urge you to please give this bill a favorable report. This is really important for all the people that we represent and that live in this state. Thank you. Next, please.
Thank you, Chair Peña-Melnick and members of the committee. Once again, it's good to be here to testify in support of SB 940. The Maryland Family Planning Program provides comprehensive reproductive health services for the state's most vulnerable residents, and in fiscal year 24, served approximately 45,000 people. In this fiscal year, we anticipate serving over 50,000 people. One of the achievements that we're proud of is that we now have a Title X clinic in every county in the state. That's why we need this bill. The updates in this bill would allow us to be able to protect the new sites, the new programs that were added since 2017. So the chair mentioned that we have prior legislation that allowed us to protect family planning programs, but it had a date of 2017 as entry. We need to update that to include all of the ones that have come since then. And it's particularly critical because most of our family planning sites are local health departments with some FQHCs, some community colleges, and Planned Parenthood as the other sites where this care is occurring throughout the state. This care is oftentimes the only source of affordable reproductive health care for the clients they serve, whether they're uninsured, underinsured, or in a position where they're vulnerable and can't use insurance to be able to get these services. And so for that reason, the department respectfully asks the committee to return a favorable report on this bill, so HB 1045.
And thank you for your partnership and always working with the committee, Dr. K. You and Deputy Lohr, everyone has been amazing, okay? And the acting commissioner, Ryan Moran as well. Thank you. Go ahead.
Good afternoon, and thank you for having me here again. My name is Karen Nelson, and I'm the CEO and president of Planned Parenthood of Maryland. I've spent decades of my career with Planned Parenthood and working with the Title X program, so I know firsthand the importance of providing patients with health care that they seek and need. The most critical element of being able to provide the exceptional patient care, or frankly, any care at all, is consistent funding from all the applicable sources. That's why I and my organization respectfully request a favorable vote on this bill. It makes the necessary changes to the family planning program in the Maryland Department of Health and allows for the continuity of our care in our family planning health centers. With the uncertainty that's been spoke about surrounding funding at the federal level, it is very necessary that the state take every action possible to protect Marylanders' ability to access all healthcare services that they may need. And that starts at making sure that the funding is secure. We at Planned Parenthood of Maryland are proud to provide a wide spectrum of care, some of it being made out to be very controversial, but this is family planning services, and it's the bulk of the care that Planned Parenthood provides, which includes birth control, preventative care, cancer screenings, even erectile dysfunction treatment. And these have never been controversial. These are the types of services currently under threat by federal actors who seek to strip healthcare providers' ability to access Title X services because of the other non-federally funded services they provide. We saw 50,000 visits last year, and 3/4 of them were family planning visits. So this is very important to be able to continue the funding to provide this care. Planned Parenthood of Maryland, as you know, services some of Maryland's most vulnerable populations, and for many, care under the Title X program will be the only care they receive all year. And we urge a favorable report. Thank you.
And thank you for your partnership.
Thank you. Madam Chair, Madam Vice Chair, committee members, Marie Grant on behalf of the Maryland Insurance Administration. As the chair noted and said far better than I could, there are insurance provisions in this bill that update the dates in our ACA protection law to reflect December 31, 2024. So right now there's like 2019 and 23. We update all of those dates to 2024. And it also gives, clarifies the Maryland Insurance Administration's role in enforcing anti-discrimination provisions that are a mirror of the federal law. So we're in strong support of this bill and happy to answer any questions.
Good afternoon. Robin Elliott here on behalf of the American College of Nurse Midwives, the Maryland affiliate, in strong support of this bill. Just wanted to underscore the importance of what the General Assembly did in 2017 and 2019, and that is for the Title X program to ensure that individuals can continue to go to the trusted providers in their communities. And so by this legislation, very important updates, so it recognizes all the new providers that have come on board since the legislation first passed. And with that, we would ask for a favorable report.
And I want to thank you for your partnership as well with this committee. I'm going to open it up for questions now. Are there any questions for these panelists? Seeing none, thank you so much for your testimony. Really appreciate you. Now we have Laura Bugley. Is there Michael New? He was signed up earlier but did not, he never showed up? Okay, so let the record reflect that he did not show up. Good afternoon.
Good
Good afternoon, Madam Chair, members of the committee. Again, I'm Laura Bogley, Executive Director of Maryland Right to Life. And we oppose this bill that would force state taxpayers to pay millions more each year to bail out abortion businesses masquerading as family planning providers. Maryland women deserve better options than abortion for family planning. By putting abortion politics before patients, the state of Maryland would put the health of women and children at risk. The time to plan one's family is before you have created a new human life, not after. Abortion is not a legitimate method of family planning, and that is why abortion businesses traditionally have been excluded from receiving federal funding through the Federal Family Planning Program established by Title X. In 2019, the Maryland General Assembly enacted what we call the Planned Parenthood Bailout Bill and refused almost all federal family planning program dollars, transferring the burden to the state taxpayers. The bill forced Maryland taxpayers to pay an additional $3.2 million, with annual maintenance effort amounts increasing year over year, to specifically exclusively to abortion providers who refuse to comply with federal Title X funding requirements. There are ways that they can qualify. They refused. This bill seeks to codify 2021 Title X rule changes that not only make abortion business eligible for family planning funding, but would actually deny public funding to any family planning provider who will not refer women to abortions. There's a mandate here to participate to refer to abortion providers. It also would increase the amount of state taxpayer funding for abortion businesses by increasing the annual maintenance of effort from the 2016 federal amount of $3.2 million to the 2024 amounts, which the fiscal note does not disclose for you. So that amount has not been revealed to the public. Maryland taxpayers should not be forced to pick up the tab for abortion businesses that continue to refuse to separate their abortion practices from the family planning services. And that's why we urge your unfavorable report. I'm happy to take questions. Thank you.
Any questions? Seeing none, thank you so much. Have a great evening. This actually concludes the bill hearing on House Bill 1045. We're gonna go now to the very patient, amazing Delegate Fair. Yay! House Bill 1059. Thank you for being so patient.
My pleasure.
And this is Health, Maryland helping everyone afford life-saving treatments and healthcare, health fund, and income tax checkoff. This is jointly assigned with Ways and Means. I don't see them here. They're in the BRFA hearing, so we work very closely together, and we'll let them know.
And I'm on Ways and Means, so
Hey,
I can play a dual role here if you'd like. My first time in front of HGO. Thank you so much, Madam Chair. And Madam Chair, Vice Chair Cullison, and esteemed members of the Health and Government Operations Committee, Delegate Chris Fair here presenting House Bill 1059. Federal healthcare programs are in disarray, directly impacting Marylanders. Between the proposed cuts to Medicaid and the specific policies targeting marginalized communities, our state's most vulnerable populations are at risk and wondering if their life-saving health care will be taken away from them in the coming weeks and months. We must do something to address the financial chaos from Washington, but in a state budget crisis year, how can we responsibly create durable financial structures that will enable our state to continue meeting the commitments it has made to Marylanders' health care? House Bill 1059 establishes the Helping Everyone Afford Life-Saving Treatments and Healthcare Fund, or the Health Fund, which is an attempt to answer that very question. It creates pathways for Marylanders to directly donate to help fellow Marylanders who can't afford their care due to federal actions without increasing taxes on anyone. Considering that at least 22% of American adults have donated to a GoFundMe medical fundraising campaign, and that nearly $750 million are raised annually on just that one platform for medical expenses, there is a strong desire among everyday people to help their neighbors afford the care that they need. The Health Fund aims to harness that desire and respond to the medical funding challenges our federal government is creating. I am under no illusions that this year's bill will offset our anticipated losses from federal funding actions, which tally in the billions of dollars. Indeed, the bill does not raise a cent in taxes on anybody. Its necessity is that it proactively creates a vehicle to receive and disperse funds donated by Marylanders trying to help other Marylanders afford their life-saving health care. In addition to encouraging charitable donations and cultivating mutual care for impacted Marylanders, establishing the health fund now will allow it to be operational to help people when funding cuts hit. During these uncertain times for our federal health landscape, state government must do everything it can to step up and protect its own citizens. HB 1059 is one of those necessary and proactive steps, creating a supplemental health care funding vehicle and enabling a pathway for Marylanders to donate towards making sure that everyone can afford life-saving treatments and health care, to create a more engaged and supportive community and fulfill our state's health care commitments. I urge the committee to give the Health Fund a favorable report. Thank you, Madam Chair.
Thank you. Do you have, oh, you don't have a panel. Are there any other questions? Any questions? All right, I do recall last week, we had another bill with a checkbox for another issue. And I know that, I believe, was it the Bay Foundation issue a letter, unfavorable letter, because they said they're one of the organizations that gets it now, and that it has reduced because there's so many others, the amount that they get. Were you aware of that?
I am, and I'll just comment a few notes quickly. In the fiscal note, they do illuminate that question. They specifically state revenues to other special funds that benefit from income tax checkoffs may decrease to the extent donations are shifted to the fund. However, any such effect can't actually be reliably predicted. I've been working with the Chesapeake Bay Trust to make sure that they are respected in this process, and we're actually working with the Comptroller's Office to address concerns about how we better market the Chesapeake Bay Trust to citizens to make sure that they know that that income tax checkoff exists as well.
Yeah, they actually, it says, they gave a letter of information, and they said, unfortunately, while all of the additional costs and many more are worthy, more tax checkoff choices lead to an overall drop in revenue across all checkoffs, as well as a drop in revenue to each individual checkoff. The reason is choice overload. Many of us have experienced this feeling in the peanut butter aisle of the supermarket, staring at 30-plus options for something we don't really need. When we feel rushed, we often give up and move on to the necessity just to finish the grocery shopping chore. So they have very strong feelings about this as well. I know usually the Comptroller's Office gives a letter, right? Because they will have to implement it. I noticed that the fiscal note does say that they can do it with assistant resources. I was wondering if you know whether they support it or not, because we didn't even get a letter of information from them.
Yeah, I don't think they took an official position. They just simply let us know that it's very doable. And again, going back to the Chesapeake Bay Trust, I'll just say I've met with them repeatedly about this bill. They generally support it as a concept. They understand why it's so necessary to do. Their concerns are the drop-off. We did pull the data for how much funding they raised through various programs, and this one compared to their license plate program, which raises anywhere between about $3 to $4 million. This program raises about $400,000.
Okay, all right. Thank you so much.
Absolutely.
All right, for, I love it. It's a great cause. Thank you so much.
Thank you.
All right,
Madam
so
Chair.
let's go to an unfavorable panel. Ms. Laura Buckley. Thank you for reaching out to them.
Yes, ma'am.
Hello again, Madam Chair, members of the committee. Laura Bogley, Executive Director of Maryland Right to Life. This is another redundant bill, another bailout bill, but I don't want to be redundant with my testimony and waste your time, so I'm simply going to say that this bill also would establish a new fund for abortion businesses, which is one of the areas that is subject to federal restrictions. So this bill deals specifically with the health fund for funding, healthcare funding, that could be restricted at the federal level. So we're talking about Title 10, any of the federal regulations that usually are political footballs from one administration to another. So of course that would include other things, but it will also include Title 10 abortion funds. And again, we just want to remind you, the multi-billion-dollar abortion industry really does not need funds. They got over $700 million in taxpayer funding last year. And again, in Maryland, we already invested in 2024, $33 million here in Maryland. That's just reported funds. So, our concern is that the bill would divert public funding from legitimate reproductive health, family planning, and prenatal care services and other providers, and further subsidize the abortion industry. Have we not had enough with abortion funding, especially with this deficit? There are certainly things I've heard today that merit funding consideration for obesity and things like that, and we're looking at line items in the budget. I would certainly say that more elective abortions is not what Marylanders need, so we urge your unfavorable report. Thank you.
You're welcome. Are there any questions for this witness? Seeing none, thank you very much for your time. And Delegate Fair, can you come back again 1 second?
Yes, ma'am.
It was your first time here. I hope you felt the love.
I did.
Are there any questions for Delegate Fair?
Oh, thank you, everybody. Thank you, everybody.
Okay, we do that for everyone. Have a blessed day, okay?
Thank you so much.
You're welcome. Thank you.
I won't tell anybody.
Have a blessed evening. Thanks for your leadership. This concludes the bill hearing on House Bill 1059. Next, we are going to go to, where's my list? Do you have the list? All right, we're going to go to House Bill 378. Yeah, 378. Yeah. Okay, and that's Delegate Woods. And while you come, I will read it. It is Prince George's County. So Delegate Woods is providing the testimony for the Prince George's County delegation. This is a delegation bill, and it's actually titled Prince George's County Assisted Living Programs Inspection. Good afternoon, Delegate Woods.
Good afternoon, Madam Chair, Madam Vice Chair, members of this Health and Government Operations.
1 second, Delegate Woods. Is Jabari Cooper here?
He had to leave out.
Okay, how about Tammy Bresnahan? Will you join the delegate so she's not by herself? Can you also pull up Juanita Fisher, Councilwoman Fisher? Go ahead, Delegate.
Yes, so I am presenting House Bill 378, Prince George's County Assisted Living Programs Inspections. It is a local bill for Prince George's County, PG 40525. And basically what the bill is asking is that the Maryland Department of Health provide an inspection for all assisted living programs in Prince George's County at least once every 60 days and provide publish an inspection report within 30 days. And this bill basically addresses staffing insufficiency and readiness concerns, quality, safe, secure, and stable housing for residents, and appropriate and maintainable quality of care in all facilities across Maryland. I do want to let you know, Madam Chair and members of the committee, that there are some concerns and discussions with the bill, that there have been some amendments proposed. And so I have been asked to let you know that this is a bill that is still in some ongoing discussion. Thank you.
Good afternoon, Madam Chair and members of the House Health and Government Operations Committee. My name is Tammy Bresnahan. I'm the Senior Director of Advocacy for AARP Maryland. And we have been in here many times about long-term care and assisted living. And we know that you all know, I actually listened to the council debate this hearing, and they must be being flooded with calls because they're at their wits' end. We know that you will make the right decision about this bill. We know that Maryland's population is aging, that a lot of aging folks depend on assisted living. They play a critical role in their care. When I was looking at another bill that I've been working on with Delegate Warman, I noticed that some of the definition of assisted living is very narrow. And then it goes on to add Alzheimer's and dementia care, because at first, the definition doesn't include medical treatment. And then as it gets down there, it defines that they may have an Alzheimer's dementia care facility. So what I'm saying is that when assisted living first came about, it was really not a medical model. It was more like somebody that just needed a couple of daily living. And now we have people with severe memory issues. I know that you know that this is an issue that we need to tackle as a state, that the health department needs to tackle as a state. And we appreciate everything that you will do and ask for you to look at this bill in a systematic way and come back with something that we can all live with. We thank you for looking at this and ask you for a favorable report with the amendments on House Bill 378. Thank you.
Thank you, and thank you for all the work you do with this committee. I know that the bill has not passed delegation yet because, as you said, they're working on it.
Correct.
So thank you for representing the delegation so well. Let's open it up for questions. Vice Chair Collison.
Thank you, Madam Chair. Delegate, why 60 days? I mean, that's like, what is that, like 6 times a year, right?
Correct. And that is one of the conversations that they are currently having and seriously looking to amend that requirement that they do it every 60 days, every 2 months. So that is something that we're having a conversation about and asking, is that really a legitimate request? Not just the 60 days, but also getting a 30-day response. So that is in deep conversation at this moment.
Great, thank you very much.
My pleasure.
Any other questions? All right, seeing none, thank you, Delegate. We do have, Donna Kaufman. And I actually probably could have called her with you, but I wasn't sure, you know? When I don't trust my gut, I always pay for it. So I was a little timid.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. For the record, Dana Kaufman on behalf of Lifespan Network. I guess I'm also the ongoing discussion. So I do have amendments. I did send them to the representative of Prince George's County. I was told earlier that they were going to have an amendment to remove that 60 days, which we would support because frankly, that 60 days would disenfranchise all the other counties. Given the number of surveyors that they have right now. So we would be supportive of removing the 60 days. As far as the annual survey, we don't have any issues with the 30 days. However, I will tell you that sometimes I've been told that our programs get an inspection in September and in January they still don't have that report. But what we want to make sure is that it's a fair and accurate report and that the report is not posted and is not provided to the council until any appeals or internal dispute resolutions are completed. Oftentimes a deficiency will be given to a program and they do a internal dispute resolution with OHCQ and it is overturned. So we want to make sure that any type of inspection is at the end of that process. We would also ask, and we've been asking this for many years now, and I thought we had received a letter that they would do this, but we think it's also only fair that if you're going to be distributing and posting the inspection report, you also pair it with the plan of correction from the program so that individuals can see how that deficiency has been addressed. We think that that is fair for everyone. So those would be our amendments.
Thank you so much. Thank you, and thank you for working with us always on our bills. Are there any questions for this witness? Thank you so much. This actually will conclude the bill hearing because Councilwoman Fisher, I was told, is not on there virtually. So let the record reflect that we did look for her. This concludes the bill hearing on House Bill 378. We have next Delegate Metzgar, House Bill 108, Public Health Abortion Heartbeat Bill. Will you be so kind and come up?
Good evening, or good afternoon, Madam Chair, Madam Vice Chair, distinguished members of the
House Health and Human Operations Committee. I am not Delegate Metzger. My name is Paul Blitz, and I am Delegate Metzger's Chief of Staff. He is over in the Bertha, and they're on number 55. So this is why I'm here, so he can do other things. Thank you for the opportunity, Madam Speaker, and others for the opportunity to speak to you today. Delegate Metzger is the sponsor of HB 108, which is titled the Public Health Abortion. However, it should be, other title would be the Heartbeat Bill. This bill clarifies that the mother of the unborn child would have a right to hear the heartbeat of an unborn child before deciding whether or not to have an abortion. It is his hope that the mother hears the heartbeat of the unborn child, that she will decide to not to have an abortion, but rather to give the child up for adoption, since so many married couples want to have children but are unable to do so. This bill will still give new life to childless couples. If a mother decides to have an abortion, the procedure must be performed by a licensed physician rather than another health care provider. For these reasons that I have given, Delegate Metzger requests a favorable report on HB 108. Thank you very much.
Thank you, and thank you for representing him. I see him sometimes in the evenings. I'm going to tell him that you did a great job. So
Thank you, ma'am. I appreciate that.
Who's next?
We have some other panel guests that we'd like to
I'll
go.
go ahead and start, Madam Chair. Laura Bogley, Executive Director of Maryland Right to Life. On behalf of our Board of Directors, we thank Delegate Metzger for introducing this important legislation, and we urge your favorable report. The bill advances the state's interest in women's health, as well as the lives of preborn children whose heartbeats can be detected. Federal courts have upheld that state laws that protect preborn children when their heartbeats can be detected are they're constitutional. 13 states currently have fetal heartbeat laws. State laws should be consistent with modern scientific knowledge about fetal human development. 95% of biologists agree that each new human life comes into existence at the moment of fertilization. A fetal heartbeat can be detected after 18 days before most women even know they're pregnant. This is not a matter of opinion or religious dogma, but scientific fact. In fact, 9 out of 10 OBGYNs refuse to commit abortions because they recognize the scientific fact that abortion kills a living human being. This bill also seeks to restore the medical standard of care to ensure women have access to safe medical procedures. Because of the Abortion Care Access Act enacted by this Assembly in 2022, physicians now serve only a tangential role on paper, either as remote medical directors for clinics or as remote prescribers of abortion drugs. With the deregulation of do-it-yourself chemical abortions, the abortion industry itself has removed abortion from the spectrum of health care and exposed women to back alley style abortions, where they bleed alone without a physician's examination or supervision. 82% of people represented in the 2025 Marist poll prefer public policies that support the life, support the needs of both mothers and their preborn children. We can do both. This bill would improve the quality of care received by both mothers and their children and bring Maryland into alignment with public opinions on abortion. So for these reasons, we urge your favorable report. Thank you.
Who's next, please?
Madam Chair, I'm Jonathan Alexander from the Maryland Family Institute in support of the Heartbeat Bill. You know, this Heartbeat Bill hits home for every parent who's ever conceived a child. For us, it was last week. My wife and I, my wife is 12 weeks pregnant, about 3 months pregnant, and she noticed that she had some hemorrhaging, and so wanted to be able to see if everything was all right with the baby. It was the weekend, so the earliest that we could get the ultrasound, this is this past week, earliest we get this ultrasound was on Monday, and we were able to see really the most reassuring and comforting image, which was on the screen, the baby's heartbeat. It was beating steadily at 162 beats per minute, and that just let us know that this child is going to be okay. I prayed a prayer over that child that I prayed over my other children, which is, may your heart beat for 100 years more. You know, the reality is that that heartbeat will probably outlive most of us. Rather in an uninterrupted way. When that child learns to run, its heart will beat faster. When we're reading them a bedtime story, its heart will slow down. When it falls in love, when a young man sees a woman, his heart will skip a beat. You know, so much happens with the engine that is our heart. And it is the scientifically proven, indisputable way for us to know that there is sign of life within that child, within that human. It's the uninterrupted universal sign of life. The only thing that does interrupt that heartbeat in this state legally is an abortionist scalpel or an abortion pill meant to stop that child's heartbeat. So this bill comes in and says for that beating heart. It should not only be loved and cherished, but it should be protected by law. That child will do everything it can to fight for life and fight for the opportunity for their heart to continue beating. And so I think we should come alongside that and protect that beating heart by giving House Bill 108 a favorable report.
Thank you, and thank you for sharing your story. And I'm glad that, that she's doing better.
Thank you, ma'am.
Okay?
Really appreciate
You're
it. Thank you,
welcome.
ma'am.
My name is Dr. Frank Arlinghouse. I've appeared before this committee multiple years testifying next to Delegate Metzger, so I know I'm not next to him now.
Flyer car here in HGO. It's
Yes.
always great to see you.
Delegate Metzger is a man of deep faith, and all of you, his colleagues, I'm sure are aware of his position and where he draws that from. I come before you to mention science in terms of embryology, in terms of genetics, in terms of fetal development. Human life begins at conception. And when we can detect a heartbeat, that's further evidence that we have a human life there. There are many different scientific markers that one could use, but these are fundamental to how we understand the life within the womb and that it's worthy of protection. From that perspective, the state has a compelling interest to encourage new life, to protect new life. Many of us have our first pictures of our children or our grandchildren as ultrasound pictures. Many of us have had experiences, much like my colleague, where we have we've watched our child or our grandchild's heart beating, and generally that heartbeat is a reason for us to leap for joy. I urge you to return a favorable report, but I want to end to mention that coincidentally, my daughter-in-law is in labor right now. She was in the hospital earlier this week, and what thing was most closely monitored? Her child's heartbeat.
Congratulations to you on being a grandfather, and I pray that all goes well with your daughter. Thank you for sharing your story. I'm going to open it up for questions now. Are there questions for this panel? Seeing none, thank you so much, and you're always welcome in HGO. Next we have, I believe, is Ken Phelps. Is he here? She testifying for him? Are you testifying for Mr. Phelps?
Yes, I am.
And what is your name?
My name is Lynn Mortoro, and you have some written testimony there from me, so you have.
Okay.
Okay.
Go ahead.
Yes, thank you. Thank you, everyone, for Madam Chair, Madam Vice Chair, and the committee for letting me have an opportunity to testify for this. I'm a retired registered nurse, originally from Connecticut, not Maryland. I did not work in women's health, but I follow rulings closely, and I am a member of the Episcopal Church and a member of MEPN, the Maryland Episcopal Public Policy Network. I found it very confusing as I was reading through that the bill is entitled a heartbeat bill, and then it goes on to state that the purpose is to take away practice privileges concerning abortion care from a highly trained and expert group who give vital care to a special group of women in our community. It then went on to state restrictions on the procedure itself. In 2022, the legislature overrode a veto by then Governor Hogan to pass a bill giving nurse practitioners, physician's assistants, and midwives the ability to train to do abortion care for pregnant people. This was in order to address gaps in care, especially among the poor and people of color. It would be a huge mistake to take this away from our healthcare system. These professionals have had education, training, supervision, and they must be certified to standards.
I'm not sure how the term fetal heartbeat is being used. A recognizable heart is not seen on ultrasound until about 16 to 20 weeks. Before that, it's the noises that the machine picks up, but it's not a functioning heart yet. Maryland law also does not require an ultrasound before any abortion. Since 1967, the Episcopal Church has maintained its unequivocal position to any legislation on the part of national or state governments which would abridge or deny the rights of individuals to reach informed decisions about the termination of pregnancy and to act upon them. Thank you so much.
Thank you for being here. I did find your name.
Request an unfavorable report.
Yeah, I found your name on the list.
Thank you.
I'm going to open it up for questions now. Are there questions for this witness? Thank you very much.
Thank you.
Thank you. And this actually concludes the bill hearing on House Bill 108. Next, we have House Bill 373. Delegate Grammer, is he here? He's not here. How about Riley Hutchinson? Delegate Riley had to go take care of a family matter, and Delegate Hutchinson has graciously agreed to do her testimony. So let's call House Bill 1357, Public Health Reproductive Health Care Data Report. You have Diana Arias, Jeffrey Trimbath, and Laura Bugley on the, no, Laura Bugley is not on your panel, just Diana Arias and Jeffrey Trimbath. And I'm going to step out. I don't mean to be, it's no disrespect. I have a meeting at 5. And I need to step out for a minute. Delegate Collison will take good care of you, okay?
Sounds good, sounds
Thank
great.
you.
So we're officially evening now, so good evening, Madam Chair, members of HGO. I'm Delegate Tom Hutchinson to present House Bill 1357, Reproductive Health Care Data Report. And it's on behalf of my good friend Teresa Riley, who had to leave unexpectedly to go home to be with her family tonight. So House Bill 1357 will better equip us with a clear understanding how to better serve Marylanders when it comes to women's health care for individuals, providers, and the state. The bill requires the Maryland Department of Health to collect and compile data annually regarding the cost of birth, postpartum care, pregnancy care, and abortion in the state of Maryland. Here are a few data requirements in the bill. For our hospitals, standard delivery including complications, emergency interventions, extended hospital stays, and neonatal if available. For our private practices, postpartum care and pregnancy care, including follow-up medical visits and postpartum mental health and depression, routine OB and GYN visits, prenatal and supplements and diagnostic testing, ultrasounds, and genetic testing. For our abortion providers, procedural costs, complications or follow-up, prescription costs, and costs of abortion care training. Now, here are a few benefits of collecting this data that will make it meaningful and impactful on how we address women's health care costs. It will identify gaps in health care access, support for family and women, address rising health care costs, promote maternal and child health, comparison with national benchmarks, and ensuring accurate and complete Abortion Data Reporting Act. The hospital providers have access to this initial data information, and 47 states have successfully gathered this data for reporting purposes. The bill requires requires the data to be sent to the Maryland Department of Health to develop a standardized system to get an overall cost of women's health care costs and services. On or before December 1st each year, beginning in 2025, the department shall submit a comprehensive report to the General Assembly and make the report publicly available on its websites. The report shall include the following information: aggregated cost data for each category of care, comparative data by region within the state, analysis of all cost data being collected, and then provide recommendations, if any, for improving cost efficiency. I want to point out in the bill, it says the department is not required to collect or report data that would violate federal or state privacy laws. There are several other places in the bill that address this concern. It is time for Maryland to act on this important legislation, to be proactive and prepare for any proposed federal requirements on this type of data collection. The passage of this bill brings accountability and transparency to overall health care costs, and I respectfully ask for a favorable report. Thank you.
Thank you, Delegate, for stepping in here. We will let Delegate Riley know you represented her well.
Thank you.
Thank you. Who's next, please?
Go ahead.
Good afternoon, Madam Vice Chair and esteemed members of the committee. My name is Diane Arias, and I'm the Associate Director for Respect Life Advocacy for the Maryland Catholic Conference. The MCC is a public policy representative for the 3 Archdioceses of Maryland, which encompass over 1 million Catholics. Maryland's annual expenditure on women's reproductive health care is difficult to determine due to the lack of publicly available aggregated data. Understanding the fiscal impact of these services is critical to assessing women's healthcare needs and ensuring resources are allocated effectively. One significant gap in Maryland's healthcare reporting is the absence of abortion data, as Maryland has not reported abortion data to the CDC since 2006, which is only one of 3, including California and New Hampshire. The state has not, in fiscal year 2022, the Maryland Department of Health reported that Medicaid funded 11,567 abortions using national data, which averaged around $659 per procedure, which estimating approximately cost $7.6 million. These figures indicate that Maryland's Medicaid program has been allocating substantial funds annually for abortion services, with recent increases to enhance provider reimbursements. According to the Guttmacher Institute, in 2023 alone, Maryland saw over 38,000 abortions, a 29% increase from previous years, including approximately 8,100 procedures performed for non-residents. In fiscal year 2025, the Moore Millett administration allocated $5 million to increase Medicaid reimbursements, and the Maryland Department of Health granted $10.6 million to the University of Maryland, Baltimore to oversee the state's abortion care clinical training program. The approximate average cost for prenatal care, labor and delivery, and postpartum care for Medicaid beneficiaries is $36,000. Access to comprehensive fiscal data is essential for ensuring associated health risks and ensuring that adequate support is available for women. The current understanding of the fiscal scope of women's reproductive health care is understood through Medicaid reporting and is solely underrepresenting other women in Maryland who have other insurance providers. I urge a favorable report. Thank you so much.
Thank you. Next, please.
Good afternoon, Vice Chair Cullison and members of the committee. My name is Jeff Trimbath, and I'm the president of the Maryland Family Institute, and I'm here today to support this bill, which we think will improve data collection for the costs associated with delivery, postpartum care, pregnancy care, and abortion. All of these issues are important. Maryland, like the rest of the country, has a birth rate well below what is needed to sustain the population. Last week, we just released our Family Structure Index, and we showed a fertility rate of 1.69 here in Maryland, which is well below the mere replacement rate of 2.1 children per woman. Undoubtedly, this contributes to Maryland's declining population, which our comptroller, as you may know, has highlighted as a significant factor in Maryland's stagnant economy. There are many reasons for our sagging birth rate, but cost is certainly a factor. I remember well the journey home from Anne Arundel Medical Center with our first, and then our second, and then our third child. It was a journey with both a bundle of joy in one hand, but also a bundle of stress due to the financial burden of having that child. This bill, which will collect data on birth, pregnancy care, and postpartum care, will give us greater insight into these expenses and new ways to support new parents and strengthen families in Maryland. Better data always drive better outcomes for parents. Collecting data on abortion costs is also important. Importantly, this bill is neither pro-abortion nor anti-abortion. It merely attempts to gather information so that we can make better decisions. Unfortunately, too much of this argument goes on in the dark because abortionists and their business counterparts in the state are resistant to releasing broader data on their policies, methods, and costs. This bill promises a big improvement, allowing for greater transparency and upholding the state's values of protecting new families. And that's why we recommend your favorable report.
Thank you. Are there any questions for this panel? Okay, seeing none, thank you all for your patience and persistence today and for your testimony. Laura Bogley? Welcome back.
Thank you, Madam Vice Chair, members of the committee. Laura Bogley, Executive Director of Maryland Right to Life. We want to thank Delegate Riley, Delegate Hutchinson for bringing this bill. And it's an important bill because it would advance women's reproductive health care by enabling the state to accurately measure the degree to which public investments in reproductive health care are actually serving the needs of pregnant women and their families. It has no bearing on a woman's access to abortion or whether abortion is legal or illegal. Abortion data has broad implications for women's reproductive health, but Maryland is one of only 3 states that refuses to report abortion data, as you heard from the other witnesses. Abortion funding data would assist state policymakers in measuring the extent to which these public investments are actually helping us to accomplish our goals, our stated goals, of reducing unplanned pregnancies, reducing the number of abortions, and improving birth and delivery outcomes. Again, Maryland is one of only 4 states that forces taxpayers to fund elective abortions. Last year alone, as you heard, Maryland taxpayers paid over $33 million for abortion purposes. While the state does not report other abortion spending, we do suspect that several million more was spent on abortion promotion through various grants and contracts, for example, with the Department of Health and the Department of Education. Unfortunately, 50 years of this public funding for abortion has failed to end childhood poverty, rape, incest, or unplanned pregnancies. In fact, the amount of abortions has increased proportionally to the increase in public funding and investments to abortion organizations. Taxpayers should not be forced to throw good money away after bad for an industry that clearly profits from unplanned pregnancy. Maryland should adopt the goal of collecting and publishing aggregate funding and statistical data on abortion on a timely basis. With this information in hand, U.S. policymakers can adopt the best approaches to protect both women and their children as the public supports. So for that reason, we support this bill and urge your favorable report. Thank you.
Okay. Thank you very much. Questions for this witness? Seeing none, thank you again.
Thank you.
I have asked, is Delegate Grammer here and I'm just not seeing him? I have asked for someone to see if they can find him and bring him up momentarily. Thank you very much, Delegate Salega. Okay. And unfortunately, Delegate Johnson, who has the other 3 bills, had to go with the chair. I asked her to send him back to me, but he's not here yet. He will be coming back shortly. And I am, so, let's see, this is 14. All right. Anything, Delegate Salega, from Delegate Grammer?
I just texted him.
I did too.
Pardon?
I texted him.
You didn't? Okay. So I'm probably going to do something that we've never done before, because everyone has been so patient and we, and I don't want to waste your time. I'm going to start with Delegate Johnson's witnesses on 1246. And when the delegate comes back, we will let him step in. So if that's okay, if I can have Matthew Prentice and, oh, Delegate Johnson is on his way back. Come on up, though. Yes. Not here yet, so why don't we go ahead, and if you'll tell us a little bit about the bill, and I can be a little lenient on the time, so we'll give him some time to get here, but, so we are now hearing House Bill 1246 with Delegates Johnson. It's Health Benefit Plans, Calculation of Cost Sharing Contribution, requirements, and whichever would like to go, you know what? I'm going to ask you guys to go sit down, and I'm going to call Delegate Grammer up.
No problem.
It's getting hot in judiciary. Thanks for pulling me out.
Yeah, you're very welcome, Delegate.
I'll get started with your permission.
Absolutely. It's
Did you want to bring up a panel? I'll leave it to you.
yes, please. Let me see. Here we go. You have Mr. Arlinghouse, Ms. Bogley, Mr. Trimbath, and Mr. Aiden. And they're real troopers, Delegate Grammer. They've stayed here a long time today. So we are now hearing House Bill 373, Health Abortion Data Submission to the Centers for Disease Control and Prevention. Delegate
Thank you.
Grammer?
Thank you, Madam Chair, members of the committee. For the record, Delegate Robin Grammer to present House Bill 373. House Bill 373 requires the Department of Health to submit to the Centers for Disease Control and Prevention any data regarding abortion requested by the Centers for Disease Control and Prevention. This is a constituent request. A resident of my district inquired as to, quote, why non-Hispanic black women have the highest rates of abortion countrywide according to the CDC. I could not find any data regarding Maryland. For clarity, she is a black Marylander and is concerned about disproportionate impacts of various policies, and she asked how this data could be collected. Maryland is one of 3 states that does not report this data. With our country's crashing demographics, I think it is important to clearly understand data and ensure no disproportionate impacts exist. To accomplish this, House Bill 373 ensures that Maryland reports our data, as do 47 other states. Thanks for the hearing for House Bill 373. Be happy to take questions, and I'd ask for a favorable report.
Thank you, Delegate. Who would like to go next?
I'm happy to. Dr. Frank Arlinghouse, asking for a favorable opinion on House Bill 373. As the delegate has laid out, we are one of very few jurisdictions that don't report this data, and abortion is one of the very few medical procedures on which we don't track data. My daughter is an emergency room nurse. She has plenty of things on which she has to submit data. So she's always surprised when I remind her that this is an area which we're unable to make data-driven decisions because we have so little data. The data that you keep hearing cited is the data that is required by the federal government for us to report because they're paying for something. But we really don't know how much abortion may have increased other than how in the state of Maryland in the last 4 or 5 years. We have very little information on which to make the decisions that other bills presented to you today ask you to make decisions on. And so I think as legislators, you would have a benefit. I think constituents would have a benefit. I think the medical profession in Maryland would have a benefit from having access to aggregate data in this critical health area. And for that reason, I ask that you issue a favorable opinion on this bill.
Thank you. Who would like to go next?
Vice Chair Cullison and members of the committee, my name is Jeff Trimbath. I'm the president of the Maryland Family Institute, and we are recommending your favorable consideration of HB 373, reporting data regarding abortion to the CDC. The subject of abortion is understandably a controversial one that has ripped at the fabric of America and Maryland for 50 years. But we're here today not to get into that important and sadly enduring argument. We're here today to stand up for good data. This is neither a pro-abortion bill nor an anti-abortion bill. It is a pro-data bill. All it does is bring Maryland into the same status as 47 other states, blue states, red states, pro-abortion states, anti-abortion states, and it does so for the purpose of transparency and research. Good data is key to formulating good research and making good arguments and achieving good outcomes for all Marylanders. As a policy research organization, the Maryland Family Institute is committed to good data, which informs the papers that we publish and the policies that we address. And this is especially so regarding abortion. Regardless of which side of the debate you are on, you should want good data. How many abortions are taking place in Maryland? Are there certain neighborhoods, economic groups, ethnic groups in which abortions are taking place more than others? Are there correlational indicators that inform this practice, such as the number of previous abortions or the number of live births or a person's marital status? All of these are important questions that could inform good policy, again, on either side of this issue. But neither side has access to them because Maryland simply refuses to report. This bill fixes that deficiency in both our data and our dialogue, and for that reason, we encourage your favorable report on HB 373.
Thank you. Next, please.
Good afternoon, Madam Vice Chair. My name is Stephen Aden. I am Chief Counsel at Americans United for Life in Washington. We were established in 1971, the original national law and policy nonprofit organization specializing in abortion, end-of-life issues, and bioethics law. Thank you very much for the opportunity to testify in support of this bill, which is a constitutional valid exercise of the state's right to ensure that accurate, reliable data and statistics on abortion procedures are available to women, the medical community, and the general public. House Bill 373 will accomplish this by requiring Maryland's Department of Health to report to CDC any data regarding abortion requested by the CDC, unless reporting it would be in violation of federal or state law. Abortion reporting is vital to preventing maternal morbidity and mortality resulting from abortion, improving women's health care by strengthening safeguards around abortion, and ensuring that not only doctors but their patients, are fully informed when treating women and their preborn children. The founder of the CDC's abortion reporting system, Jack Smith, put it this way, quote, "Public health is very much part of the abortion issue. Moral and constitutional questions related to abortion may be argued philosophically. However, health questions related to abortion should be answered by sound epidemiologic reasoning based on adequate abortion statistics." You've heard these witnesses say that Maryland is one of only 3 states that does not report this data to the CDC. And in fact, I would also note that Maryland currently reports around 70 diseases or other conditions, reports the data surveillance for that. That's how important data is in this area. It's critical that reliable, authoritative, and accurate abortion data and statistics be available to women, the medical community, and the general public to address the known risks of abortion. So we ask for a favorable report. Thank you, ma'am.
Thank you. Ms. Bogley, you want to move up to the table?
Thank you, Madam Vice Chair. Laura Bogley, Executive Director of Maryland Right to Life. Exactly what they said. Very well done, gentlemen. On behalf of the Board of Directors of Maryland Right to Life, we want to thank Delegate Grammer for bringing this bill to advance reproductive health care and providing abortion data to the Centers for Disease Control and Prevention. Again, this bill also has no bearing on a woman's access to abortion or the legality of abortion. The Supreme Court has held that abortion reporting requirements are constitutional. There's nothing here that would prevent you in the law from doing that. Yet, unfortunately, again, as you've heard, since 2006, Maryland is one of only a few states that refuses to provide abortion transparency by reporting to the CDC. Again, in 2024, Maryland taxpayers paid $9.1 million in state Medicaid for about 12,518 elective abortions. Again, less than 11 of those abortions that public funds paid for through Medicaid were for reasons of rape, incest, or to save the life of the mother. The Maryland Department of Health has unfortunately consistently failed to provide for the needs of pregnant women just simply by refusing to report accurate data to measure the number of abortions and related health complications, injuries, and deaths. This data also is necessary for any comprehensive studies by the Maryland Maternal Morbidity Review Board to address the correlation between abortion and subsequent pregnancy complications, fetal and maternal deaths. And we do have evidence to show there is a correlation between abortion and complications in future pregnancies and with future fertility. If the state really believes that abortion is health care and that it's a moral good, I don't understand why we are here time in and time out in session not treating abortion like any other medical procedure. As the witness said here, 70 other types of health data is reported to the CDC. Why are we singling out abortion if it's health care? I just recommend that you be consistent, provide that important information so we can improve our services to pregnant women and families. For that reason, we urge your favorable report. Thank you.
Thank you. Questions for this panel? Seeing none, thank you again.
Thank you so much.
Thank you for running up here, Delegate, and you all for your patience this afternoon. That concludes the hearing on House Bill 373. And Delegate Johnson, I was just about to turn your bill over to your witnesses when Delegate Grammer ran in, so. Yeah. So now, we are going to hear House Bill 1246. That's Health Benefit Plans, Calculation of Cost Sharing Contributions, Requirements. Delegate Johnson.
Thank you, Madam Chair. Looks like I get the Triple Crown trifecta end of the day here. Good afternoon, Madam Chair, Vice Chair, and committees or members of the HGO Committee. For the record, Delegate Steve Johnson here to present House Bill 1246, Health Insurance Coverage for Specialty Drugs. Marylanders living with chronic and rare conditions rely on high-cost specialty drugs to offset high out-of-pocket costs. The patients will apply for and receive copay assistance. Most of the copay assistance is provided by pharmaceutical manufacturers to patients taking one of their products. Copay assistance is also provided to patients by some nonprofit organizations. In recent years, health insurers and pharmacy benefit managers have begun implementing new programs that prevent any copay assistance funds from counting towards patients' deductibles and out-of-pocket maximums. These programs are often referred to as copay accumulators or copay maximizers. These programs eliminate any benefit from copay assistance and result in a significant financial barrier to accessing treatment. Instead of refusing to accept copay assistance, insurers and PBMs pocket the assistance funds and then double down by again collecting the full out-of-pocket cost from the patient. When facing high out-of-pocket costs, patients do not use their medications appropriately, skipping doses to save money or abandoning treatment altogether. To date, 19 other states, including our neighbors, Virginia, West Virginia, Delaware, and the District of Columbia and Puerto Rico, have passed similar legislation. So what exactly does House Bill 1246 do? It ensures that copay assistance, a vital source of financial assistance for Maryland patients to afford medication, will count towards deductibles and out-of-pocket maximums. And how the legislation does this? When calculating an individual's cost-sharing requirement, insurance carriers and pharmacy benefit managers must include amounts paid by the individual and by other persons on behalf of the individual. The legislation separates healthcare benefit design from the availability of the patient's assistance. Now, we're going to hear that things that we've always heard in the past. Copay assistance steers patients towards high-cost drugs instead of cheaper alternatives. Data shows that for all commercial market claims for specialty medications where copay assistance was used, only 3.4 of those claims were for a product that may have had a generic alternative available. But simply, patients are using copay assistance for drugs that do not have a cheaper alternative. These are often the only drugs that are available to the patient and prescribed by their doctors as being the best for them. We're going to also hear that health insurers and PBMs do this to keep premiums low for everyone else. There's no evidence to suggest that premiums have increased in states due to legislation enacted to ban copay accumulators. We can provide the analysis that show this. The real issue is the price of these drugs and the pharmaceutical companies. This legislation does not conflict or even need to relate to other legislation aimed at drug prices or PBM reforms. This legislation simply requires insurers and PBMs to apply the copay assistance that patients use towards the individual's out-of-pocket cost. And we remain open to work with anyone on this bill. And for these reasons, I urge a favorable report on House Bill 1246.
Thank you.
Let's go next.
Thank you, Delegate, who, I guess Mr. Prentice wants to go first.
Sure. Thank you, Madam Vice Chair and members of the committee. My name is Matt Prentice, and I'm the Director of State Policy with the Immune Deficiency Foundation. On behalf of the Maryland All Copays Count Coalition, explaining what this does, I'll just add a few other points. 2025 a report from this year conducted by the AIDS Institute found that 50% of marketplace plans in Maryland have copay accumulator adjustment policies, so this is an issue here in the state. And I just want to reiterate that copay assistance doesn't steer patients to costly medications. It only provides financial help to access the medications their doctor has concluded is best for them and that their insurance provider has already approved. One other note I want to add, since we have been working on this for a couple years, we really support this legislation as a step in the right direction, and I want to commend both the delegate and the committee's efforts on this issue. But there is legislation in the Senate right now, Senate Bill 773, that also is approaching this issue. And the one difference I'd point out first, and really can talk to the other pieces and differences in the bill, is that House Bill 1246 does not have a specific provision that prevents an administrator, carrier, or PBM from altering a health plan's coverage based on the individual's financial assistance available. And so the goal of this provision is really to address other policies and programs like copay maximizers or newer efforts around copay assistance like alternative funding programs that, from the patient perspective, we believe continue to misuse copay assistance funds and create access barriers. Again, I want to reiterate that 21 other states have done this, and we respectfully request your support.
Okay, thank you. Mr. Kilpatrick?
Thank you, Madam Vice Chair, members of the committee. For the record, my name is Lance Kilpatrick. I am the Maryland Government Relations Director for the American Cancer Society Cancer Action Network, here in support of House Bill 1246. So some of you saw, we recently held our Cancer Action Lobby Day here in Annapolis. Over 50 cancer patients, survivors, family members, and caregivers coming together to discuss issues of importance to them, including this bill. In talking with these volunteers, not one discussed how they convinced their healthcare provider to prescribe a more expensive medication because there was copay assistance available to them for that medication. When a patient has a conversation with a doctor, it's about what is the best treatment to get the best result. This legislation is about mitigating the out-of-pocket costs patients incur while taking needed medications prescribed by their healthcare provider based upon medical and scientific evidence. Period. Full stop. Thank you so much for the opportunity to testify today.
Thank you. Questions for the sponsors panel? I would just ask the sponsor, are you still in conversations about potential amendments?
Yes, Madam Vice Chair, yes, we are, Madam Chair.
Thank you, Delegate. I appreciate that. And thank you all for your time and testimony today. I'm going to call, and we have one unfavorable. I'm going to go ahead and let Michael Johansson speak, and then we'll do the panel, the last panel of favorables. Our official chair would notice that you're lonely, Mr. Johansson.
Well, I like it up here. Thank you, Madam Chair. I'm Mike Johansson on behalf of PCMA. PBMs implement programs that their health plan sponsor asks them to implement. If a health plan sponsor says, don't do this, we don't do it. We turn it on or turn it off based on their decisions with respect to how they want their plan run, including whether a coupon or copay assistance counts toward deductible. There was a reference that there aren't generic drugs available in many circumstances when someone uses one of these drugs or coupons. We have a study, and I can provide some more information. 88% of the high-cost brands with coupons had lower-cost generics or brand alternatives available. Coupons are offered by companies that make something and they want someone to access it. It creates kind of a loyalty, with that product, and that same effect happens here. The federal government, for example, doesn't allow that activity because they see it as incenting perhaps higher cost activity, so they prohibit it completely. So it's not prohibited. Even if someone uses a policy to not count it towards your deductible, you still get the value of the coupon. You still may pay less, but you just don't get to count it toward your deductible. Now, this bill, interesting, has a provision that we do like, which says that if you're in a high deductible plan, then it wouldn't count toward that high deductible. That's a positive. This bill is different than the Senate bill. We understand there's some amendments. We work for health plan sponsors, including carriers. If the carriers come up with amendments that they're comfortable with, we will be comfortable as well. Thank you.
Thank you. That's very fair. Questions for Mr. Johansson?
Thank you.
No, and I think we're getting very familiar with the issue.
Yes.
So I think I appreciate that. So let me bring up Matthew Celentano, Dana Kaufman, and Kimberly Robinson. I haven't seen, there she is. This is an interesting panel.
It's my friend Dana.
I think this is dangerous.
Here goes our friend Dana.
And Kim, you want to start?
I'm sorry, did you ask me to start, Madam Chair?
Yes, go ahead.
Sure. Good evening, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield. In favor of the bill as introduced. I heard some talk of amendments, so I look forward to talking with the sponsor about what they may look like. We worked with the sponsor quite a bit last year on the bill, and so this year's bill reflects amendments that had been offered in 2024 that helped us be more comfortable. There was a comment made in the proponent panel that carriers are pocketing the difference based on the coupon. I do just want to clarify that that is not true. Coupons are not rebates. They don't come back to the carrier. They are point of sale coupons like you use when you buy soap or bread. They happen at the point of sale, and that's going to be between the manufacturer of the drug who has chosen to offer the coupon and the retailer who is selling it, who processes that coupon. We don't actually have our hands on that coupon, but it is reducing the cost for that member. As the bill is before you, it does have some important safeguards to ensure that people are not driven to higher cost drugs that they would then stay on and have a coupon expire, leaving them exposed for that difference in cost. We think that's a very important consumer protection, particularly when the patient is in fact indicated for the generic and does not have to be on the branded medication. We don't want them driven to an unnecessary cost. So as this bill has been put together, it is far more akin to the laws that you have seen in the other states referenced, as opposed to the Senate bill, which is vastly different than what our neighboring states have passed, or last year's bill. And so as introduced, we appreciate the language that exists today. And I will conclude there.
Dana, you want to go next?
Thank you very much. For the record, my name is Dana Kaufman. I'm here on behalf of MedChi, sitting in the middle. I'm starting to question.
We've been at tables a lot this year, Dana.
But very simply, we do support very, very much the accumulator programs. We do support this bill, but we do understand that there are differences between the House and the Senate that need to be worked out. So we're very willing to come to the table and help to reach a compromise so that hopefully this year we can finally pass this bill. So thank you very much.
Thank you.
Madam Chair, Matt Celentano here today on behalf of the League of Life and Health Insurers in support of House Bill 1246. We want to thank Delegate Johnson for bringing this bill and the important conversation forward. We had a really
productive conversation about coupons and discounts offered by manufacturers last year, which led to this legislation that protects consumers, provides guardrails on out-of-control drug pricing from the manufacturers, and informs consumers about the availability of these coupons and when they might expire. We think this is a really important consumer protection provision. Consumers should be aware before a manufacturer pulls the rug out from under them. We're really pleased to support the bill as introduced, and we are hoping for a favorable report. Thank you.
Thank you. Questions for this panel?
Come on, Dana.
We do not want this on record.
That's what I'm thinking. You know, it's like when I get that group together and they're all saying yes about something, it's like, something's right.
It's not the first time this year, I'm just saying.
But with some nuances.
Right.
Yes, with some nuances.
Seeing no questions, maybe next year. But thank you all very much for your patience in waiting. And we have two virtual witnesses, Sally Amaro and Amakali is the last name, I believe. Okay, so let's have Sally. Good evening, Ms. Amaro.
Oh,
You may go ahead and testify.
well, thank you so much. And thank you for the opportunity to speak in support of House Bill 1246. My name is Sally Amaro. I'm a resident of Montgomery County, and I'm here today to represent people like me who are living with an immune deficiency disorder in the great state of Maryland. Immunodeficiency covers many ways in which a person's immune system can be affected. But in general, we experience severe recurring infections like pneumonia, a host of comorbidities like asthma and arthritis, and in some cases can face life-threatening situations. In fact, just over a year ago, I was fighting for my life in Johns Hopkins Hospital in Baltimore. The standard treatment for immune deficiency disorders is immunoglobulin replacement therapy. When given by infusion, by intravenous infusion, this treatment can cost $7,500 to $10,000 each shot and is given every 3 to 6 weeks. And of course, as you accumulate your comorbidities and other consequences, the cost can skyrocket. While my health insurance covers most of my cost, patients who have other health insurance plans in Maryland can face much higher, even formidable out-of-pocket expenses. Many rely on copay assistance programs to help cover these expenses and access the world-class medical care that is available in our state. Therefore, I respectfully request that you support House Bill 1246. Thank you.
Thank you. Thank you very much for your patience and for sharing your story and making it real for us. I appreciate it. Questions for this witness? Okay, seeing none and no one in the waiting room? Oh, okay. Then that concludes the hearing on House Bill 1246. We'll move to House Bill 1243. Delegate Johnson? Good idea, just staying down there. House Bill 1243 is health insurance coverage for specialty drugs.
Thank you, Madam Chair, members of the HGO Committee. For the record, I'm Delegate Steve Johnson, here to present House Bill 1243, health insurance, pharmacy benefit managers, specialty drugs dispensed by a physician. House Bill 1243 is a bill that you should be very familiar with, as it's nearly identical to the legislation this committee and the full House passed unanimously last session. House Bill 1243 creates a very limited exception to Maryland's current law to permit cancer patients to access essential specialty drugs directly from their physicians in a community oncology practices. The bill includes several provisions to mitigate any potential cost increases, including limiting dispensing to low-cost community health settings, reducing costs from duplicative dispensing and wasted drugs, and requires carriers and dispensing physicians to agree on a reimbursement rate, helping to ensure reasonable but transparent pricing. In addition, or in anticipation of this hearing, the proponents have been working closely with all stakeholders and the Senate committee to address outstanding issues, and we are optimistic that this is finally the year for this important bill that benefits cancer patients throughout Maryland. For those reasons, I ask for a favorable report on House Bill 1243.
Thank you. So Caitlin McDonough, and can you bring up Dr. Ferozi? Is he in the waiting room? Okay. Caitlin, you want to go ahead before we go to questions?
Good evening, Madam Chair, members of the committee. Caitlin McDonough on behalf of Maryland Oncology and Hematology, here in support of House Bill 1243. Delegate Johnson did a good job reminding us of this bill. This is a bill the committee will recall we've been working on for several years, and it's been through a lot of narrowing iterations. Excuse me. And and we are actively working. Mr. Celentano and I spoke earlier today about language around that reimbursement piece. We understand the committee's desire to move forward with allowing this type of physician dispensing and allowing it to be covered, but the concerns about cost. So we're just trying to figure out what that reimbursement looks like. We do need to have some insight into what that rate would be and some assuredness going forward to allow us to stock and function properly and be able to actually provide this essential service to our patients. Dr. Frosby is on the line. He's an oncologist with MOH and can explain, the more technical clinical aspects of this and why MID is so helpful for our patients. But I'll thank the committee and, hope to have your support again this year. Thank you.
Thank you. Dr. Ferozi, go ahead. Why don't you go ahead? You're on mute right now.
Okay, can you hear me?
There we go. Yes, we can. Thank you.
Thank you. Good afternoon, Madam Chair, members of the committee. My name is Dr. Kasha Frosby, and I'm an oncologist at Maryland Oncology Hematology, here in support of House Bill 1243 regarding patient steerage of specialty drugs to PBM-affiliated pharmacies. Maryland Oncology Hematology is the largest independent community oncology practice in the state of Maryland, seeing over 77,000 patients a year across 15 locations. We provide access to cancer care services for all patients, regardless of insurance status, and we do millions of dollars a year of charity care per year. Maryland already recognizes the detrimental effects of patient steerage in healthcare. Our state has enacted laws to prevent this practice in other areas of healthcare, acknowledging that patients deserve the freedom to choose their providers and make decisions that align with their best interests. House Bill 1243 seeks to extend this protection to the specialty drugs, particularly to oral oncolytics, ensuring that cancer patients have access and can receive the critical medications that are needed and provided by their trusted physicians and care team. But this is not simply a matter of convenience. This has several areas where it impacts the overall care of patients as well as the overall health expenditure for the health system. Benefits from providing medications directly from the physician's office include enhanced communication from all the members that are involved in the multidisciplinary management of the patient, including patients who are receiving surgery or radiation and may need to have medications held prior to initiating those treatments. Improved adherence. We have demonstrated in our own internal quality assurance studies that patients who get their medications through our MID have significant improved adherence compared to those patients who are not receiving their medications through our MID. Reduced waste, which is tied to lower cost. Being that we're continuing to manage these patients, are aware of what's going on with their treatment, we're able to avoid unnecessary prescriptions that cost $10,000 to $12,000 a month for a prescription that will ultimately be wasted. Furthermore, independent oncology practices like ours have consistently demonstrated that we can deliver high-quality cancer care at lower costs than other facilities. We have worked in good faith with our bill sponsors and other stakeholders on this issue in the last few years to ensure that we meet the needs of highly complex cancer patients. We appreciate the time you've invested in this committee as committee members to learn about this issue, and I would like to extend personal thanks and appreciation to Delegate Johnson and all the members of this committee who have spent time trying to learn about this important issue so that our patients can get the care they need. Thank you.
Thank you, Doctor. Okay, questions for the sponsor or his panel? Delegate Hale.
Dr. Ferozy, can you just tell me, will this help your impoverished patients, particularly those with insecure housing who are unhoused, to get the timely chemotherapeutic treatments that they need?
Yeah, anytime we can improve the care coordination and reduce the fragmentation of care, especially for those patients who have a lot of social determinants of health that impact their ability to sort of get communication related to those medications, it helps. I will tell you that a lot of patients who have unstable housing oftentimes are not available to receive phone calls from outside PBM pharmacies. And as a result of that, I have found that those patients, when they do show up to my office, they oftentimes don't have the medication because they're not able to connect with that outside pharmacy. They've oftentimes asked, can we just pick it up when we see you? And unfortunately, that's not always possible.
Thank you.
Okay. Seeing no other questions, thank you, Delegate, for this bill, and to your panel for their patience and endurance. Speaking of endurance, I'm going to call Mr. Johansson back up and do the unfavorable first, and then we'll do favorable with amendments.
Thank you, Madam Chair. I'm Mike Johansson on behalf of PCMA. So this comment about steerage was mentioned yesterday, and it was mentioned again. It was kind of a good hearing until we got to that point. Steerage is apparently referring to integrated PBMs, healthcare plans, and specialty pharmacies that they may have as affiliates. But let's talk about what steerage could be in a different perspective in the bill that you have in front of you. The doctor prescribing a medication and dispensing, selling the medication. Some oncology practices are affiliates of major drug distributors. McKesson owns US Oncology Network. McKesson's a drug distributor. So steerage could be the guy that distributes the drug, the physician who works at an affiliate, dispenses a drug to a patient, and gets paid for it. So I didn't like that comment, and I think it should be taken in a broader context. I do have a nice little chart that talks about McKesson, the number 9 company in the Fortune 500. AmerisourceBergen, the number 10 company in the Fortune 500, which also owns an affiliate called One Oncology. Nonetheless, there is an important protection in this bill that says this practice would only occur if they reach agreement on payment with the health plan. So to that extent, it's a modest, soft opposition.
Thank you.
Thank you. All right.
I appreciate that. Are there any questions for Mr. Johansson? Seeing none, thank you again.
Thank you.
I'm sorry, I missed that. Delegate Taveras.
I'm sorry. Mr. Johansson, just so that I'm clear what I hear, that I'm hearing what you're saying. So, and I'm not trying to make this, accuse anybody here of anything, but is this, but this is kind of like the case of OxyContin. Is this kind of like what you're saying, that people would go in and pitch a drug, or they could be a representative of the drug?
So this,
I'm just trying to understand.
Yeah, no, this is not OxyContin. We're talking about drugs that are needed and medically necessary. It's a question of who is selling the drug to the patient, for which the health plan is ultimately responsible to pay for. It's nothing like the patient coming in asking for something that they probably shouldn't have, and a physician just, sells it.
My apologies. Yeah. I'm not trying to allege that it wasn't medically necessary.
Correct.
What I'm sorry, at one point it was, and then it got abused.
Correct.
I'm just saying during the portion of time that it was medically necessary, that's where the problem began.
In that situation, my understanding of that problem was the doctors began writing scripts for favors they were getting from the drug manufacturers, perhaps, but they weren't actually dispensing the drugs in office. This is actually a medical practice that is owned by a drug distribution company, so they are acquiring the product at a wholesale price from the drug distribution company. It is medically necessary, no one is challenging that, but then they are selling it at the retail to the customer for someone at the health plan to pay for it. So it is an integrated system, so those who would be concerned about PBMs being part of integrated systems, I'm just trying to suggest it could be an analogous situation.
Okay, thank you.
Thank you.
Okay, thank you very much. So I'm going to bring up favorable with amendment panel, and it's large, so maybe a couple of people could sit with Mr. Johansson while they're waiting to come up to the table. Daniel Shattuck, Angus Worthington, Matt Celentano, Dana Kaufman, Kimberly Robinson.
Madam Chair, members of the committee, I'm Dan Shattuck, here today on behalf of Arthritis and Rheumatis Associates. I want to thank you, Madam Chair, and I want to thank the bill sponsor, Delegate Johnson, for your perseverance on this issue. As was mentioned earlier, this bill has been before the committee for a number of years. We've been loyal and dedicated stakeholders to this issue. The bill before you is narrow to medical oncology, and we're here in support of the bill with an amendment that would add rheumatology and rheumatology patients after a year, taking into account the notion that we want to start narrow to show that, you know, specialty networks won't fall apart, that this won't be the end of specialty prescribing as we know it, but wanting not to leave out an important patient base, being the rheumatology patients and providers, and Dr. Worthing can go into more detail. The amendment that we submitted with our testimony basically takes effect a year after the bill has been in effect, so it gives it time to, you know, operate. We can get a sense of how things go, but after the year, January 1, 2027, rheumatology would come into the law under the same rules and obligations that the medical oncology physicians and prescribers would have to abide by. So it would just save us a step from coming back in a year to come before this committee again, as much as we like to come before this committee. It's a novel approach. We hope that it gets considered. Obviously, treating the oncology patients is important, but again, there's other patients out there that would benefit from this as well. So we just want to be part of it. Thank you.
Thank you. Appreciate that. Dr. Worthington? Worthing.
Thanks, Madam Chair, members of the committee. I'm Angus Worthing. I'm a rheumatologist at Arthritis and Rheumatism Associates, physician-owned, Maryland's largest independent rheumatology practice. Very grateful to be here to represent my patients with autoimmune diseases. I'll be very frank with you, most of my patients with stable housing, as was brought up, are getting their autoimmune specialty prescriptions through the mail, and it's working okay. But some must or strongly prefer to fill it at the pharmacy of their choice or my office for many reasons. One is they can get an in-person injection teaching for these medications that are lifelong. It's not a single course of therapy, giving themselves an injection. Another is that the medicines are delicate and can spoil on their porch, it can freeze in the winter, it can be mishandled. There's extreme weather events like hurricanes that delay the mail. People with rheumatoid arthritis pay for those delays by disabling joint pain, not getting their medications, or permanent internal organ damage that sometimes needs to be treated with toxic steroid medications. So now we're grateful, Maryland is poised to close this loophole that allows PBMs to steer people to their pharmacies. And unfortunately, it's only for cancer patients. So who are the other people that are taking specialty drugs? I want to tell you autoimmune diseases affect predominantly women. 4 out of 5 of my patients with autoimmune disease are women. Systemic lupus, one of the major diseases, and also rheumatoid arthritis predominantly affect people of color. The market for autoimmune specialty drugs is bigger than cancers. So you're excluding more people than you're including, and you're excluding women and people of color. So please consider our amendment so that my patients with autoimmune disease can fill their drugs at my office when it is best for them. Thank you very much.
Great, thank you. Kim, want to go ahead?
Good afternoon. I feel like I'm too short to see over the monitor. I'm fine, thank you. Good afternoon, Madam Chair, members of the committee. Kimberly Robinson for Care First Blue Cross Blue Shield. I'm here favorable with amendments on the bill. As you heard, we've been working for many years to move this bill along and try to find a way to make it effective for both sides of the equation, for the oncologists and their patients, as well as for our members who are in their care. For the record, I am not a PBM. I am an insurance company. I am not a PBM. Just want to remind the committee, because I know you've seen me wearing other hats, but that is not the perspective from which I'm speaking. But as a carrier, one of the things that we do want to make sure happens in the bill is that it has a nod to the fact that there is a cost that could be uncontrolled, depending on how we shift to the in-office dispensing. And so we have had very good success in our conversations with Ms. McDonough and her client, and feel like we're actually getting very close on finding language that is going to work for both sides of that equation. I have not seen Mr. Shattuck's amendment. I don't know that a year from now we will have been able to successfully have contracted with even just the oncologists to know if we've been successful in having them be able to participate in the network and come to agreement. But always happy to continue talking with the committee and certainly with the sponsor, Delegate Johnson. And so with that, we look forward to further consideration of the proposal.
Thank you. Dana?
Thank you very much. Again, for the record, Dana Kaufman on behalf of MedChi. This is actually the 7th session that this bill has been introduced. Yes, it's the 7th. It went in 2019. It was very, very broad-based, and it has been, due to the concerns that have been raised, it has been very narrowly crafted now, and it only is referring to oncology services for in-network providers. We do have one amendment dealing with that section of the bill, and that's the phrase medical oncology. We want to make sure, because there are other specialties that treat cancer patients, like urology, who specializes in kidney and bladder cancers, that they are not inadvertently exempted from this. So we are just asking for the term medical to be taken out. I also just want to point out, too, that on page 4 of the bill, there is language right now that does talk about the rate has to be agreed upon by the in-network provider and the entity, as well as billed at a non-hospital level of care. So we do believe that any cost issues are being addressed. We welcome the opportunity to work on that language a little bit more if necessary. But again, it does say agreed upon. So just wanted to point that out. And with that, I ask for your favorable report when we get all the issues worked out. Thank you very much.
Great, thank you. Matt, you want to go ahead and, before I ask for questions?
Madam Chair, members of the committee, Matt Celentano here today on behalf of the League of Life and Health Insurers in support of House Bill 1243 with amendments. I want to thank Delegate Johnson and Delegate Cullison, as well as the advocates, for giving us a chance to work through our challenges on this legislation, and I think we are going to get to a place of support. There are still some concerns from the carriers around the definition of specialty and the reimbursement guardrails. We want to make sure that consumers do not pay more in these kinds of situations. But we've already been in communication with Ms. McDonough. I think she mentioned that earlier, and I am fairly confident we are going to get to a place of comfort very shortly. So with that, I hope for a favorable amendment report. Thank you.
Thank you. Questions for this panel? Delegate Woods.
Yes, I know you coming from a different perspective, but from Dr. Worthing, I was wondering if you could talk a little bit more about how the federal plans and Medicare address maybe the steerage versus how the commercial plans that we're speaking of now address it.
Thanks for that question, Delegate. They're very different. We've been dispensing medications, specialty medications, for about a year now. And it's almost exclusively for our patients who are in federal plans like Medicare. And that's because Medicare doesn't allow steering. And so our patients who which works out well for them. Their Medicare beneficiaries are generally over 65, and they'd rather learn how to do these injections in person with my medical assistant instead of YouTube or online. They, like all of our patients, they want to avoid these gaps from delays in the mail. When people who have autoimmune diseases, I mentioned with joint pain, if there's a long enough gap between injections, these are large immune active molecules, patients can become immune to it in the next dose, which means that the medication stops working. And in a disease that hasn't been cured yet, we will hopefully cure this, that person needs some other medication for the rest of their life. So after a gap, if the drug stops working, they'll come back in, we'll have an appointment, we might need to use toxic anti-inflammatory steroids like I was talking about, and then get them onto another medication, which is all cost and time and disability and other things. So Maryland does allow for that steering and the commercial plans, whereas federal plans like Medicare, that's not allowed. And I'll mention also in response to your question that Senate Finance Committee voted unanimously November 2023 to support these kinds of and other anti-steering reforms. Federal Trade Commission supported it last summer. So,
You mean U.S. Senate?
Sorry.
U.S. Senate. You don't mean
The U.S. Senate. Sorry, not this Senate. Thank you. I'm sorry about that.
Thank you.
Thanks for the question.
Any other questions? Seeing none, thank you all again for your, why do I keep missing your light? I am sorry, Delegate Taveras.
I'll make sure I get more beautiful for you. I'll put on more lipstick. No, so just a quick question. We want to make sure that we see that the bottom is not dropping out of the, that everybody is satisfied with the financing in the first year or two of this. But at the other end, I know that you want to be able to include the arthritis and rheumatoid disciplines, I would say. So that's why I'm trying to understand. So, and because of the fear, how long do you think you would need? And I'm asking this of, how much time do you need, Ms. Robinson or Ms. Hoffman, to realize what it is?
Thank you for the question, Delegate Taveras. As I said, this was the first I heard of their amendment, so I honestly could not respond on the moment because I've known about it for like the last 10 minutes, and I am not the expert in that part of the business. I would have to go back and talk to my provider team, who would have much more perspective as they are getting their heads around what the bill is looking to accomplish and can follow up.
If we could get some numbers so we could kind of see, I think that would be helpful to at least
On the timing,
a
right?
significant portion of the market.
We'll see
we're
what they can
grappling
produce.
with. Thank you.
Well, we'll be discussing that in subcommittee as well. Yeah, definitely. Any other questions? I'm going to take a real look and see no more lights. Thank you all very much. That concludes the hearing on House Bill 1243, and we go into the last bill of the day, which is House Bill 813. Delegate Johnson again. This is Delegate Johnson's day. It's Pharmacy Benefits Administration, Maryland Medical Assistance Program, and Pharmacy Benefit Managers. So you have Michael Patty, Christine Lee, and Steve Weiner on your panel, Delegate.
Thank you, Madam Chair, members of the HGO Committee. For the record, I'm Delegate Steve Johnson, here to present the last bill of the day, HB 813, Pharmacy Benefit Administration, Maryland Medical Assistance Program, and Pharmacy Benefit Managers. House Bill 813 is a bill that this committee is very familiar with. It would mandate reimbursement parity for pharmacists dispensing medication under the state's Medicaid Management Care Program. so that they are reimbursed at the same level as under the fee-for-service program. Basically, this bill would require that pharmacists who are Medicaid patients this bill would require that pharmacists who serve Medicaid patients are at a minimum reimbursed for the it's a long day, ingredient cost of the drug and for dispensing services they provide. Currently, under managed care programs, MCOs are significantly underpaying pharmacists for their dispensing services, less than 50% or 50 cents per drug, far below the $10.67 per drug that Maryland Medicaid has determined themselves to be the appropriate amount. The result is it's just not financially viable for pharmacists to dispense drugs under the managed care program, and similar to other health practitioners who serve Medicaid patients. If you don't cover the cost of those services, you will see a direct impact on practitioners' ability to continue to provide services. That may mean closing or significantly limiting hours of high Medicaid areas, cutting back on pharmacy staff because the reimbursements don't cover those wages, or the inability to fully stock medications when pharmacists take a loss every time they dispense a drug. Not only is the current system shortchanging our Medicaid pharmacists, but it is also shortchanging the patients that they serve. This is particularly true for some of our smaller independent pharmacies who don't have the ability to offset those losses with other sales and business practices. These are pharmacies that often provide services in places where providing care might not be profitable. But the longer they are forced to dispense without compensation, the harder it is for them to stay in those locations. I recognize increasing reimbursements for these practitioners comes at a cost, but that is true with everything the state chooses to prioritize and properly fund with Medicaid services. Medicaid pharmacists shouldn't be given, or should be given, the same consideration afforded to other Medicaid practitioners. Now, you all know that I owned a pharmacy for about 20 years, independent pharmacy. We provided most of the community services in that community, and we got to where it was actually just could not stay open. So I ended up selling my pharmacy. I did not sell it to a chain because I wanted to keep a community pharmacy that provided the community services around. So I sold it to an individual. That individual did not last a year and a half. So we're asking our pharmacies to do more and more and to be a stronger link in the healthcare chain, especially in underserved areas. But they cannot do that if we consistently continue to underpay them. You cannot ask any business to do more and not pay them for the services they are providing. And for those reasons, I would ask for a favorable report on House Bill 813.
Delegate, who would like to go next?
You go.
I guess I'm going next. Good evening, members of the committee. My name is Steve Weiner. I own 2 pharmacies in Baltimore City. I'm here to urge a favorable opinion on House Bill 813. My testimony has, I don't know if you'll read it. I don't feel like reading it. Essentially, it says we're paid fairly by Medicaid fee-for-service. We're not paid fairly by the MCO program. I give some figures. 1 out of 5 prescriptions under the MCO program are reimbursed under cost. When you consider it costs me way more than $10.67 to fill a prescription because we do delivery and compliance packaging. 90% of those prescriptions are reimbursed what it costs. Between the 2 stores, it's about a $12,000 loss per month. So what are the ramifications? Things we provide like free delivery, compliance packaging, they're now a la carte. Some people can't afford them, but we can't afford to offer. 2 CVSs, 1 in my zip code, 1 zip code away, are closing April 1st. Walgreens at Mercy Hospital closed last week. the administrators at Walgreens, because my pharmacy at Healthcare for the Homeless is the closest pharmacy to Mercy Hospital. And they said, Steve, will you help us? Will you help our patients? One of my competitors closed, and my response is, I will help you temporarily if you will commit to taking these patients back once you get your pharmacy up and running. Did you ever hear of such a thing? I'm doing them a favor by helping patients that closed that Walgreens. They didn't close the Walgreens because they were profitable to the Walgreens. And I'm doing them a favor so these patients have somewhere to go. These are the ramifications of a system that is unsustainable. Last year, I told you pharmacies were closing. I never thought it would be the chains. But the tipping point is here, folks. I appreciate a favorable report, and I appreciate you bearing with me. Thank you.
Thank you. Christine?
Good evening, Christine Lee. I own Professional Pharmacy in Rosedale, Maryland. So I have some data to share too. So for all the MCO plans in 2024, I filled just over 5,600 scripts. Out of those 5,600 scripts, I lost on just acquisition costs alone on 1,640 of them. So about 1 in 3. Those prescriptions cost me $123,000 to purchase. So if you think about how much money that is and how many employees I could have provided nice bonuses for or had in my store if I would have spent those funds. But no, I spent them on drugs in which I was reimbursed $117,000 for. So I spent $123 and I was reimbursed $117,000, which is a $5,000 loss. And that does not include how much it costs to actually dispense the drug. If I take that into account, I'm actually at a loss of an additional $20,000. So as Steve mentioned, access is definitely an issue. This isn't an independent pharmacy issue. I live in Voley's Quarters, Middle River, and my pharmacy is in, like I said, Rosedale. 2 pharmacies, a Walgreens and a CVS, have closed in January. So it's just simply not sustainable, and I ask for a favorable report and to come with some sort of, I don't know. I understand it's a huge fiscal note and that there's a lot of questions about that and how that report was put together. I get we need to have conversations about that, but I truly feel there needs to be some sort of resolution because, you know, we talk about patients not being able to take meds because they're not affordable. Well, patients aren't going to be able to get medications if there's not pharmacies to be able to serve these individuals. So thank you for a favorable report.
Michael?
And Michael Patty here today on behalf of the Independent Pharmacies of Maryland in support of House Bill 813. I just want to again thank Delegate Johnson on all of his work on this issue and dealing with me in the interim and early in session, particularly around the fiscal note. And you know, this isn't the first time this committee's heard the bill. And just to give a brief recap on where we've come, because I know this committee likes work being done in the interim, and we've tried to do that. In 2023, this bill got turned into a report that MDH completed. They responded to the report. Unfortunately, the report didn't really address what we were anticipating in what we had proposed in the bill. Last session, the bill got reintroduced as it is before you again. There was a lot of discussion on what the report, the numbers that were used in the report, and those numbers that were reflected in the fiscal note. We're back again with the same bill, and the fiscal note is now different. There was a big multi-million-dollar number that has now been changed to indeterminate. I think we're going in the right direction, but more importantly, since last session, 2 states have passed this exact model, or very close to it, New Mexico and Nebraska. And while those 2 states aren't states I typically get up here to talk about, I think it's important that, you know, other states have committed the resources to figuring out this issue in the Medicaid space. States like West Virginia and New York are saving millions of dollars reevaluating how they handle pharmacy services and the relationships between the state PBMs and MCOs. And I think that, you know, if not this bill as it's drafted, I think, you know, this committee can dedicate time in subcommittee to figuring out the best way to move forward, to continue to figure out how to keep independent pharmacies viable. I'm not going to restate about pharmacies closing. We know they are. We know they're laying off staff and reducing hours. Other states have done this, and it's working and saving money. I think this bill could be a vehicle to reevaluate Maryland's stance on the issue. Thank you.
Thank you. Questions for the sponsor and his panel? Delegate Kipke.
Thank you, Madam Chairman. Just a quick question to our good friend and pharmacist, Stephen Weiner. I know doctors, primary care doctors can decide whether or not they participate in Medicaid. Some do, some don't. I'm sure it's an economic decision. Why would you participate in Medicaid?
Thank you for the question. No business person in their right mind would accept the terms of the MCO reimbursements. They're the rock bottom of any category of reimbursement, and as we've discussed, they're under cost for most pharmacies. Besides the fact that we've grown up in these communities, we care about them. As we've discussed in the past, there's 3 pharmacy benefit managers that control upwards of 85% of all the prescription spend in the country. When they negotiate these MCO contracts, they're bundled in with retail and Part D. A pharmacy cannot refuse to be in an MCO. So 7 of 8, maybe 6 of 8, I don't want to be called a liar. The majority of MCOs are processed by Caremark, associated with CVS. If I decide not to participate in one, I will most likely not be in any of the MCOs, not just the one that I can't agree with, but I'm going to get removed from multiple retail and Part D networks because they're bundled. It's not individual. We've got no choice. We've got a gun to our head, and we're dispensing ourselves to death.
Thank you.
Delegate Taveras.
Mr. Patty, I just want to make sure that I understand. You said that New York and what was the other state were saving a substantial amount of money because I just need to follow what I didn't hear very well.
Oh, yeah, sure. So there are a number of states, but yeah, I referenced New York and West Virginia. They've reevaluated how their state interacts with PBMs and MCOs, and a group called the Independent Pharmacy Cooperative has put together a lot of great information, but these states did audits of how their MCOs and their PBMs interacted with their patients, determined that there were savings if they moved to a different model, and I'm proposing that this bill could be used as something that we could figure out if Maryland should move into a model like that.
Thank you.
Okay. Delegate Hill.
Thank you, Madam Chair. So, Mr. Patty, letter from the Department of Health Information notes that this bill would essentially reverse the General Assembly's policy direction of allowing MCOs to administer medical assistance programs, and that the reimbursement rates for MCOs not even reimbursement rates for dispensing fees. I know you spoke about just the acquisition fees, but the dispensing fees, where in commercial it was $2 per claim, they were paying 67 cents per claim and 59 cents, just not sustainable. Now, the feds have been looking at MCOs pretty significantly the last year. Do you have any information about how the feds might be moving to deal with MCOs in the pharmacy space?
I don't have any of that information at my fingertips, but I'm happy to follow up with you, though, with it.
All right, thank you.
Okay. Seeing no further questions, thank you all very much. And I have an unfavorable panel, Michael Johansson and Joe Nguyen. You have company now, Mr. Johansson.
Could ruin his reputation here. You want to go first?
Sure, I'll go first. Madam Chair, members of the committee, good evening. I'm Joe Nguyen. I'm the Executive Director of the Maryland MCO Association, here on behalf of the 9 Medicaid MCOs that arrange for care and health choice. This bill, as was referenced, has been around a few sessions. My comments are pretty much the same. Like a lot of employer organizations, health plans, some unions, even the state of Maryland, about 90% of the market that offers benefits relies on PBMs to help control the cost of prescription drugs. In Maryland, Medicaid's about 20% of the market. If you think about the population, 1 in 5 people are covered by Medicaid. The pharmacy spend is over $1.2 billion in Medicaid. It is a very expensive part of the Medicaid program. We rely on the PBMs not just to negotiate on our behalf. All large plan sponsors do the same thing. It's in addition to the negotiation on cost, they also do a host of other services which are necessary and important, and plan sponsors rely on them for both network management and a host of other services like formulary management as well. The MCOs rely on the independent pharmacists in our networks. We need them, and all the MCOs use them. And I appreciate the point of view from the independent pharmacy team that came up here. However, this bill is just too expensive. Madam Chair, my comments that I submitted cite the older number. The updated number is indeterminate, but could be tens of millions of dollars. And we're facing a budget problem, and this bill is just too expensive. And 10xing something in cost is not going to help. I don't see how that creates savings. So we request an unfavorable report on the bill, and I'm here to answer any questions the committee might have. Thank you.
Thank you.
Thank you, Madam Chair. I'm Mike Johansson on behalf of PCMA. PBMs represent their plan sponsors. If a plan sponsor says pay all pharmacies more or some pharmacies more, we would certainly do that. We do bring to our plan sponsors a negotiated price for a network of pharmacies that typically includes more than 80 or 90% of the pharmacies in the region agree to accept the rate. The 2023 study, by the way, which the department did, repriced 10 million prescriptions in 2021 and 11 million prescriptions in 2022 that the MCOs had processed with their PBMs. So when they ran their fiscal note to figure out how NADAC pricing would work and the dispensing fee would work, they reran over 20 million scripts and repriced them. So that's where the data comes from. The concept of a different model is basically saying that MCOs wouldn't contract directly with their PBMs. Perhaps the state would have one big PBM, like the state health plan is one PBM as compared to multiple. The problem with that model is managed care organizations receive capitated payments, mean they accept the risk and they manage care. That's the model that Maryland passed in 1996. And having a PBM that works directly with them means that the MCO's care management team, when they do utilization management, when they do prior authorization, we've talked about those types of tools, they work directly with the PBM that they feel best suits them. I happen to represent also an MCO called Maryland Physicians Care. They work with their PBM, and in some cases, the PBM pays the claims, but the MCO has brought in-house the medical management decisions, such as care management, so that they can make determinations with their medical staff whether even it's a prior auth and it should be approved or not. So it's not kind of a one-size-fit-all. And when you have managed care organizations that have tremendous risk for ensuring that the care is delivered and that they would accept any losses if there's not. Make one final point. I know it's been a long day. Unfortunately, to some degree, Medicaid in all states are based on the concept that they pay the providers generally less than they do in the commercial market. Hospitals get paid less for the same procedure for a Medicaid patient than they do in the commercial market. And that's set by HSCRC. It's an absolute set discount. What you're hearing here is the contracts that the pharmacies are accepting for commercial payment are low and they're also low for the MCO's Medicaid. What they're suggesting, which is kind of unheard of in Medicaid, and I understand the need, and if the state provides the money, we will pass it through. What they're suggesting is they should be paid more in Medicaid than they accept in their commercial contracts. If there is any cost to this bill, the prior reports the department has suggested 70% would go to large pharmacies and 30% would go to independents. The state did have a $5 incentive payment one time for rural pharmacies. Those are the types of strategies that you could implement for people that have high Medicaid. Nursing homes used to get a little bump if they had really high Medicaid, for example. If someone has a high Medicaid population, urban, rural, wherever it is, maybe the state could come up with a narrowly tailored program to provide some incentives or benefit. And if that's what the state dictates, we will pass it through.
Okay, thank you. Questions for this panel? Delegate Taveras.
No, I gotta wait. So I'm just trying to figure out who's responsible for a bad negotiation, right? And then, and who needs to calculate, and where do we need to calculate the real sunk cost of the drugs and delivery? Thank you.
Well, chains typically negotiate, large companies negotiate with the large PBMs. And typically they are negotiating across their business. It usually doesn't differ very much between commercial and something like managed care, which has commercial components. Independent pharmacies use organizations called PSAOs, Pharmacy Services Administrative Organizations. If you remember my last chart with the integrated vertical column with the drug distributors, many of the large drug distributors have PSAOs that they use to negotiate prices with PBMs, and those drug distributors help supply product to the retailers that are part of their PSAO network to try and achieve cost savings. So there's big parties on all sides of this conversation.
Okay. Good. So I wanted to ask, do PSAOs negotiate with MCOs as well?
PSAOs negotiate on behalf of their independent pharmacies with PBMs. The PBMs handle the negotiations for the MCOs.
For the MCOs, okay, sorry. It's been a long day. I knew that. Other questions? Seeing none, thank you both very much. Thanks for, I think this is the last time for you, today for you, Mr. Johansson.
I think I'm back tomorrow for some reason. I can't remember why.
This is my first time at the committee this year, so it's nice to see all sorts on this.
Good to see you, Joe. This year. Can I have Sarah Price, Caitlin McDonough, Aaliyah Horton? Yeah. Here are the real troopers. Aaliyah, you want to go ahead and get started?
Sure. Aaliyah Horton of the Maryland Pharmacists Association. We're the professional society for pharmacists, pharmacy technicians, and student pharmacists. We are in favor of this bill. Christine Lee Wilson and Steve Weiner are members of MPHA. As a professional society, you know, I come up and I talk about the pharmacists, and this issue is very important to our membership. It's very simple in that the pharmacies are basically subsidizing the program, and that just doesn't make sense. And you talk about all of these, the formulas and how they're negotiating, but at the end of the day, Medicaid is not paying for what they're getting. They're underpaying, point blank period. The Department of Health has determined how much it costs for dispensing, and they're getting pennies on the dollar for doing that work. And even now, we have some regulations that are going to go into effect next year on accessible labels, on pharmacies having to provide accessible labels on demand. I know this is a little bit different than what we're talking about, but that's another unfunded mandate that's going to be on pharmacies that they have to deliver. All of this is impacting the pharmacy and pharmacist ecosystem, and pharmacists are coming out of school not wanting to work in community pharmacy because it's not looking viable. It doesn't look like a sustainable pathway for their careers. And if you look at the overall pharmacists in the workplace, it has typically been about 50% are in community pharmacies and the rest are around in industry, academia, and other areas. And they're shifting away. So pharmacies are closing. The ones that are open are not going to have enough pharmacists in the pipeline. And it's just getting worse and worse. And so I hope that we can come up with something in subcommittee or commit to real work over the summer to get some type of restitution for the pharmacy community. Thank you.
Thank you.
Go ahead, Sarah.
Sarah, you want to go next?
Good afternoon, Madam Chair, Madam Vice Chair, honorable committee members. Sarah Price here on behalf of the Maryland Association of Chain Drug Stores. I want to take the opportunity to comment a little bit on the study that was previously done, the one that came up with the, I believe, $78 million price tag of what we know pharmacists are essentially being shortchanged for their work. When that study was put through, we were hoping that the department would not just do the simple math of multiplying the number of dispensed medications by the increased dispensing fee, but also take a look at what some real PBM reform could do to the cost. What would these drugs cost if the PBMs were not marking medications up by hundreds or thousands of %, as we know that they're doing based on the FTC's second interim report that I know has been reviewed a little bit in this committee earlier this year. Obviously, that is not the study that we received, but we do know that there are a multitude of states that have put some PBM reform into effect. There are a couple of different options. We know that you can remove pharmacy benefits from the MCOs. We know that you can set up state mandated pass-throughs. We have numbers. We know the tens of millions of dollars that some other states have saved, and we do hope that this committee will take the opportunity to see what can actually be achieved in this area to try to maintain the pharmacy industry in Maryland. So we would urge a favorable or some kind of work or something, please and thank you.
Thank you, Madam Chair, members of the committee. Caitlin McDonough on behalf of Epic Pharmacy Network, here in support of House Bill 813. The previous panel and Steve and this panel, I think, has already spoken to, the devastating impact of some of these discrepancies in reimbursement for pharmacists. But I just want to note, as kind of one of the last panelists, that this does impact patients as well. When we close, when we limit our hours, when we only have one person working the desk, and when we just can't stock drugs because we're not being paid for them, that impacts patients, and not just Medicaid patients. Anyone in that pharmacy is going to be impacted by those implications. So as you're deliberating, and I know there is a fiscal note, but just remember, it's not just the pharmacist or the pharmacist versus the PBMs on this one. Those patients are impacted as well, and we do urge a favorable report and thank the committee for the work on this bill, the other bills that, on these issues in prescription drugs and access to drugs that they've been working on this session. Thank you.
Go ahead. Thank you. Questions for this panel? Madam Chair.
You have a question, Delegate Hill?
Oh, sorry.
Just because
Oh my God, I should have just stayed on my meeting. Go ahead, Delegate Hill. What is your question?
You've been going strong.
Yes, I'm sorry, I didn't catch your name again.
Sarah.
Sarah. So I want to make sure I understand this right.
Mm-hmm.
So the fiscal note was 78 million. And what that means is that if we were to take it out of the MCOs or require that they pay a minimum which at least covers the actual cost, it would be 7-8 million, which means, as I think you said, the pharmacists are supping up $7-8 million, right? And there are sort of two ways. There's what you pay and what you're reimbursed. So if we're being told in these vertically integrated healthcare, pharmacy distribution things that we can't adjust the reimbursement, then we ought to at least be looking, can we adjust what they're charging you, right? Because it shouldn't be you who are delivering to the patients sucking up $78 million worth of loss if the MCOs, as they crunch their capitated numbers to make sure they're profitable, are sucking up profits. There must be some additional profits that they could distribute the wealth a little bit. Is that kind of what you're saying?
That's our understanding, yes, that somewhere in the system, whether it's within the MCO, whether it's what the PBMs are negotiating, the money is there, and we believe it could be distributed a little bit more equally.
Thank you.
Delegate Bandari.
Thank you, Madam Chair. You heard the opposition panel. They claim that it mainly benefits large chain pharmacies. How would you respond to this concern by highlighting how the bill specifically support independent and rural pharmacies and is very cost effective for the state and also ensure patient access to necessary medications?
Yeah, well, and thank you for the question, Delegate. And using some of Mr. Johansson's numbers, I mean, even if we're 30% of that, 30% of 78 million is going to go a long way with my independent pharmacies. But, it is partially about like where these independent pharmacies are located in the populations they're serving. They do tend to be, and I think we've been in previous years with maps and locations and things like that, where there are underserved populations, community populations, and, they don't have the same mobility and flexibility to move that a larger store might have based on business model and profitability. So they do, I'm getting tired, but they do tend to be kind of stuck holding the bag a little bit with these under reimbursed prescriptions. So, I mean, I think we do see a disproportionate impact on those independent pharmacies, even if it's not as much in the overall pie, but, at an individual level.
Thank you.
Thank you.
Any other questions? So I was looking at the fiscal note. As you know, the fiscal note is a little pesky thin this session.
It's down a little.
And it states that it will have a significant but indeterminate amount, likely by millions of dollars, right? So being realistic, seeing a fiscal note like this, it's not going to pass, right? I mean, it's impossible. So I was thinking that, and I was talking to my vice chair and Delegate Kipke here, that we have not done anything on PBMs serious work in like more than 4 years, last 4 years or so, like a study or anything like that. So I was thinking that if we can turn this bill into some kind of work group, and Sarah, you inspire me to look at what other states are doing, because I've been thinking a lot about that. What are the other states doing? Because I know New Jersey has done great work, and I have colleagues from New Jersey that tell me about it, and I just want to know what's out there that we can do that is not so costly, right? But that we will profoundly improve, right? And it should be both for the private and Medicaid market. I just don't want it for one. I know that the ERISA bill has some language in there for MIA, but let's see, hopefully that will pass, right? We passed it from the House. So if we can work on that, that would be great. So this is what I'm gonna do. I would like you, ladies, all three of you, to work with the sponsor of the bill and Delegate Johnson with the department and Mr. Johansson, and to see, I included all of you, okay, to see what we can come up with, some kind of study that we can make this into a work group. And if you can ask MIA and Medicaid to staff it, they should be able to staff this. And most importantly, below 75K will be great, okay? All right, usually we don't work our bills because we have subcommittee, but I just did it. So in any event, any other questions? Seeing none, This concludes the bill hearing on House Bill 813, and it concludes the work for the evening. I would like us to stay just seated for 30 seconds while we go down. That would be great. I know that Delegate Kerr, you're very popular. You have a lot of people waiting for you.